Hello, good morning, everyone. It's a great pleasure to moderate this 16th ASID School. This has been a tradition since long time now that the African Society of Immunodeficiency organized this kind of school. So it's really a pleasure to be this time chairing it with my colleagues. And I'm also very happy to be here with all this group of colleagues from Africa, from abroad, and from the US, from UK, and this is a great pleasure. I would like first of all to thank our colleague Reem El Faqi, who did really has been very active organizing this school, and unfortunately for personal reasons she's not able to be with us today, but I would like really to thank her for all her efforts. I know that she has been also helped by Nahla Irwa from Sudan and Ryan Gouda from Sudan as well. I would like to thank them very much for their efforts organizing and putting together this 16th ASID school. So it's my pleasure to start the day today, and I will be moderating the sessions with my two colleagues, Nahla Irwa from Sudan and Nermeen Galal from Egypt. I introduce myself. I'm Rida Barbouche from Tunisia, and I'm an immunologist working at the Pasteur Institute of Tunis and at the Medical School University of Tunis. So great pleasure to start the program today. I know that there are a few housekeeping points that I would like to discuss with you, and the most important one now, you know, it's a school, so we need to have the students contributing, and we wanted to be very active. So it's extremely important for the success of the day to have all the students putting their questions on the chat, on the YouTube chat, questions that will be, of course, discussed after each of the presentation by our colleagues. So extremely important, please put as many questions as you want on the YouTube chat, and we will discuss them one per one after each of the talks. So just put to whom the question is destinated, of course. So this is the most important point. We will go through some other housekeeping points a little bit later during the day. So I think that this is really a great opportunity for me and for all of us. This is a very interesting topic. So the topic chosen was primary disorder of phagocytic functions, diagnosis and management. This is a very interesting topic because we have some specificity in our region. We have some data in our region which could be discussed with regard to the literature and the presentation of our estimated colleagues from other regions of the world. And I think it's a disease that is very frequent, at least here in our region, in the North African region. We have many cases of CGD, which are really sometimes difficult to manage, and we want to deal with also these aspects with our colleagues from abroad and discuss with them different questions that are arising around these diseases. So excellent topic that has been chosen by the ASID board. I thank you again, and I'm really counting on your efforts, those who are present, all students who are here, to put as many questions as you could, so we have a very interactive session today. So I will stop here, and I will give the floor to my colleague, Professor Nermeen Galal, who will introduce the first speaker.
Good morning, everyone. Very happy to be part of the ASID activities as usual. And now I'll present our first speaker for the day, Dr. Nahla Irwa, Clinical Immunology Consultant, Assistant Professor from Soba University Hospital and Faculty of Medicine, University of Khartoum, Sudan, and our past ASID President. We look forward to her interesting talk. Nahla, please start.
Hello, good morning, good evening, good afternoon, wherever you may be. Thank you very much, my dear colleagues, Professor Rida and Nermeen, and my ASID board members. And thank you for coming today to join us on the Phagocytic Defects School by ASID. The job that was assigned to me was to introduce the topic and to introduce what the phagocytic defects are all about in total, and also to allude to the IUIS classification in relation to these defects. So I just thought perhaps since we are talking about phagocytic defects, it is not going to be fair if we do not mention a little bit of history about this magnificent and fascinating method of or of immunity. Phagocytosis has been identified as an active process of the immune response over 100 years ago by a Russian scientist. He was a zoologist, actually. His name was Eli Metchintov. And for his observations that there were special cells attacking small thorns which were placed into starfish larvae. And then following on from these observations, he could actually pick on the magnificent process of phagocytosis of bacterial antigens within the body by certain macrophages and neutrophils. He was given he was awarded the Nobel Prize in 1908 together with Paul Ehrlich, and they were jointly given this award as they both presented two complementary kind of methods of immunity as we understand them these days. But at that time, people thought that they were contradicting or contrasting. So this Russian zoologist was phenomenal in the introduction of the basics of cellular immunity, while Paul Ehrlich was the one who introduced the first thoughts about humoral immunity. And then if we start thinking about phagocytosis, we all heard about it since very old days of school as a method of nutrition for unicellular organisms, such as the amoeba, for example. And we studied that. We studied the formation of pseudopodia and of the phagosome and all that. And perhaps that was one of the very first observations as well. And now we know that phagocytes recognize and ingest any particle which is larger than 0.5 micrometers into its plasma membranes and form the phagosomes in order to deal with these particles. So phagocytes of the human body are many, and they are very well organized into a well-formed network, if I may say, of cells that are present in almost all tissues of the body. And together they form what is known as the reticuloendothelial system, and I would say and beyond. Functionally, they can be divided into professional phagocytes and non-professional phagocytes. The professional phagocytes are all those cells that are derived from the bone marrow progenitor myelogenic kind of blasts. So, and they constitute the macrophages that we all know, and which take different names in different tissues, in different tissues of the body. They also make the monocytes, and sometimes we call the macrophages and the monocytes the macrophages, while we call the neutrophils, which are the front lines of our innate system, the microphages. So all these are known as professional phagocytes, and as I said, they are present in all sorts of tissues, in the lungs as alveolar macrophages, in the spleen as splenic macrophages, in the liver as Kupffer cells, in the kidneys as mesangial phagocytes, and in connective tissue cells as histiocytes, in the skin as Langerhans cells, and so on and so forth. Important ones are also the osteoclasts, which also contribute to the homeostasis of our bone. There are other non-professional phagocytes, which are cells, other cells of the body, mainly of the epithelial and the endothelial systems, as well as the fibroblasts. And these can actually do some phagocytosis, but they seem to be more important for tissue homeostasis rather than getting rid of microorganisms or fighting infection. So phagocytosis in the human body passes through some important stages, especially if we are dealing with one of those efficient professional phagocytes. The first stage would definitely be the identification of the abnormal or the organism or the pathogen that's coming in through certain receptors. And I will describe some of those receptors a little bit later. And then after recognition or identification, the cell needs to move towards that innocuous substance, which is more than 5.5 micrometers. And the mechanisms include chemotaxis and adhesion molecules. And then the actual phagocytosis or engulfment through the phagosome formation and its maturation. And by maturation, we mean that there is a full formation of a phagosome completely enclosing the organism and fully capable of producing all sorts of killing enzymes, such as lysozymes and other killing mechanisms, such as the reactive oxygen molecules through the oxidative burst and the nitrous oxide and all that. And all these lead to digestion and killing. And the eventual outcome of this would be not only killing of the organism, but also presenting it to cells of specific immunity, such as the T cells, in order to make a more specific and a more potent and a more long acting immunity, which are the signs of a secondary immune or a specific immune response rather. So what would be the results? What are the functions that are meant to happen? What are the outcomes that would happen as a result of phagocytosis in the human body? The obvious one is the elimination of pathogens and other foreign substances. But there's also the elimination of apoptotic cells or of apoptotic bodies. Phagocytosis also is important in the mediation of inflammation and the clearance of the battleground. So the phagocyte doesn't only get rid of infection, it helps us with getting rid of all those apoptotic bodies and with controlling inflammation, if I may put it this way. And to do this, there are all sorts of mechanisms and molecules and tools that can contribute to these functions. And here I just chose to put some of the receptors that are known to work as identifiers of the foreign substances. And broadly, the human phagocytic receptors are divided into pattern recognition receptors. And these, by the way, exclude the toll-like receptors in this case. And they also constitute of opsonic receptors, which are receptors that would only act in the presence of additional plasma proteins, such as the immunoglobulin molecules and the complement molecules, through the specific receptors that are present on the phagocytes. And also there are some apoptotic receptors. And these apoptotic receptors are detectors of certain apoptotic body molecules. for an efficient kind of action by the phagocyte, there is very well organized and very well organized, let's put it this way, cooperation between the different receptors. So for potent identification and intracellular engulfment and further downstream molecular signals, there should be a degree of very well coordination between these and cooperation between these receptors in order to get rid of the specific molecule. Another important tool that I would like to allude to, because you will be hearing about it quite a bit through this talk, is the NADPH enzyme, which is composed of many molecules. And this is the main enzyme that is capable of producing superoxide molecules, which are killing or killers to the most of the pathogens. And it is an important one. I would like you to look at it and try to remember it, because it constitutes the mechanism which, if not present, makes the disease that is known as chronic granulomatous disease, which I think is among the most common phagocytic defects. Now, having thought about phagocytosis, its mechanisms and its tools, I would like to start talking a little bit about phagocytic defects. And the prototype defects that we tend to speak about whenever we mention phagocytic defects include neutropenias with all their types, chronic granulomatous disease, and the leukocyte adhesion defects. So these are probably the most well identified and studied ones, and perhaps they are among the more common of the phagocytic defects. In anticipation of what we have already discussed in terms of mechanisms, we would be able to anticipate possible clinical presentations in the absence of a perfect phagocytic function. And these possible clinical presentations include infections, which are in most cases under the umbrella of phagocytic defects would be due to a limited range of organisms, mainly bacterial origin and fungal origin. And these infections usually occur in the form of abscesses, either deep abscesses or skin abscesses, and also in the form of sepsis or osteomyelitis and other types of infections. Another issue that might arise from an abnormal phagocytic function would be a dysregulated inflammation or hyperinflammatory or a hyperinflammatory state with granulomata formation. It may also result, such dysregulated inflammation or hyperinflammation may result in an inflammatory bowel disease-like disease or a presentation with what is known as periodontitis. There is a group of patients who may present with autoimmune manifestations, and in a recent study from Turkey, about 50% of their phagocytic defect patients actually presented with autoimmune manifestations. And this doesn't only occur in patients, but it also occurs in carriers of the defects. Now, what do we expect to find under such circumstances where the phagocytic defects are not normal? We may expect to find neutropenia in cases of neutropenias, obviously. But in cases of leukocyte adhesion defects where the leukocytes cannot travel to the infection site, we might also find neutrophilia. We would also expect to find an abnormal oxidative burst or abnormal phagocytosis, but the assays for phagocytosis are a little bit less well standardized. Other findings may include hypergamma globulinemia and other abnormalities with the T cells in syndromic patients. Now, how frequent are phagocytic cell defects? This is a very difficult question because there is no neonatal or newborn screening program available to date to tell us about definitive figures of frequencies, prevalence, or even incidence. So we take it that the frequencies vary with the region, the country, the intermarriages, consanguinity, and obviously the study under scrutiny. And the incidence varies from one disease to the other, but in general, these diseases vary from 1 in 100,000 up to, in their commonest forms, up to 1 in 500,000 or so. And by far, it seems that CGD is the most frequently identified disease of phagocytic defects. And just to, because I don't have, like specific figures, I chose to present you some recent data from relevant regions. So in a group of 807 Algerian patients with inborn errors of immunity, 7.1% of them presented with a phagocytic disease of some form, with CGD being the most frequent. While in Egypt, 20% or 21% of 500 patients presented with phagocytic defects, and this came only second to severe combined immunodeficiencies. So it is a profile which seems to be different to what is seen in the Western countries. Yet another regional kind of study from the UAE, it's the United Arab Emirates, also identified 8.6 of its cohort as having a congenital defect of phagocytic number or function. Now, let me remind you that all of these countries, whether Algeria or Egypt or the United Arab Emirates, are all countries of high consanguinity, and they have been working on their, especially in the case of Algeria and Egypt, they have been working on their cohorts for quite some time now. Now, I would like to move on to the classification question. Classification is important. Why is it important? Because it guides diagnosis, it may guide prognosis and will help with the management of the patients. And it's also very important to conduct research. It unifies the language that we speak. So it's important to know classifications. And how are inborn errors of immunity classified? They can be classified by clinical presentation using the clinical and the immunological phenotypes. They can be classified by pathogenesis or by genetic defects. It is always best to have some sort of a classification that would combine the three of these. In Africa, we have this program known as the A project, and we have a level 1A project, which is a very basic program to encourage awareness and to encourage doctors to pick up as many patients using the available tools and only clinical kind of picture in that. And with this program, it was proposed that PIDs could be grouped into 4 main groups. Obviously, this is very basic. The combined T and B cell immunodeficiencies, the antibody deficiencies, the innate immune deficiencies, which include the complement and the phagocyte defects, as well as PID associated with syndromes. If we look at these, we find that we can pick up patients using age of onset, clinical features, microbiology, laboratory analysis, using some basic things, and the treatment could be done using standard treatments. And here there are some examples as well. So in this table, the third column involves the phagocytic defects, and most of them can appear anytime from early birth. And these patients can present with all sorts of infections, including liver abscesses, skin abscesses, lung abscesses, stomatitis, or delayed umbilical stump separation, especially in the case of leukocyte adhesion defects, and or recurrent meningitis, but that's more for the complement. The range of organisms include Aspergillus as the main fungal disease, Staphylococcus, and atypical mycobacteria. Let me say here with the microbiology that we have to look very carefully at these patients, because in different regions, the range of organisms may vary. So maybe we have to look at endemic infections which are presenting with severe, persistent, unusual, or recurrent infections to pick up unusual patients, which may be patients with an inborn error of immunity. And the lab analysis would look for neutropenia or the MBT test. We can treat them using prophylactic antibiotics and prophylactic antifungals, sometimes GCSF. And the prototypic diseases include the severe or cyclic neutropenias, the CGD, the LAD, the complement deficiencies, etc. A more international method of classifying inborn errors of immunity was designed by the IUIS expert committee, and lately a phenotypic classification joined as well. The IUIS expert committee first met in 1970. So IUIS stands for International Union for Immunological Societies. So this expert group met for the first time in 1970, and they discussed 16 diseases only. And the first report was published in 1973, and then that was updated every second year. The term inborn errors of immunity was introduced to replace primary immunodeficiencies in the title of the document that came up in 2017. And the latest document appeared in 2019, actually the beginning of 2020, and it included 416 inborn errors of immunity. Now we know that there are over 450 genetic defects, and since 2013, a companion color-coded phenotypic classification document was introduced to help with the diagnosis of these patients. And this last document we are trying to use to help us develop some Africa-relevant guidelines using perhaps endemic infections as examples. So this is the document that was the last document. So this is the current IUIS classification, but because of this, an explosion of genetic diseases and the explosion and advancement in genetic methods, the authors felt that they needed an interim updated report, because the next one is not coming until 2023 or 2022. So maybe this year we'll hear more about these classifications. And in this interim report, there are at least 26 new diseases. And here are some graphs that I have extracted from the IUIS classification document from 2019, showing the exponential growth in the number of defects reported between 1983 and 2002, and the respective increase in number of cases in the different tables. The classification by the human inborn errors by the IOIS group classifies inborn errors of immunity into into 10 groups from 1 to 10, and each group comes in a separate table. So the first one is immunodeficiencies affecting cellular and humoral immunodeficiencies, then the combined immunodeficiencies with associated syndromic features, and the predominant antibody deficiencies, and diseases of immune regulation. And the fifth one is actually the one on congenital defects of phagocyte number and function. This is the focus of our topic today. Defects of intrinsic and innate immunity are in table number 6. Autoinflammatory disorders are in table number 7. 8 includes complement deficiencies, and 9 and 10 were newer tables introduced between 2015 and 2019 to include bone marrow failures and phenocopies of inborn errors of immunity. The reason why I have insisted on putting this on is to remind ourselves that immunodeficiencies are true inborn errors of immunity. And these patients, by just saying that these patients have immunodeficiencies, there is some sort of stereotyping in the thinking of many that would draw the attention to susceptibility to infection and to ignore other effects that may result from an inborn error of immunity, such as immune dysregulation, abnormal inflammation, or other problems. Now, I just want to speak very quickly about the phenotypic classification, which is this document that started to appear since the year 2013. It's another important document that we would like all our candidates and all our colleagues to have a look at, because it is supposed to be a more user-friendly document or classification that serves as a source for the clinician at the bedside. So it helps patients, helps doctors when to think about what to look for and what makes which disease when they are found together. And in this phenotypic classification document, the disease names are presented again in tables which correspond to the tables of the International Union classification. So there are 10 tables. And the disease names appear in red, while the genes that cause them appear in bold italics. And to help further, there's also a smartphone application which people can download and which can help them with diagnosing patients at the bedside. Today, I'm going to focus on table number 5, which talks or which expresses and describes congenital defects due to phagocyte function or number. The first one is the congenital defects of number, mainly the neutropenias, and it is further divided into neutropenias associated with syndromes and neutropenias which are not associated with syndromes. And perhaps some of the famous names that you may have heard about, especially our friends, the pediatricians, the Shwachman-Diamond syndrome, and the glycogen storage diseases, and Cohen syndrome, and many others that you may have heard about and dealt with during your practice of neonatal and childhood diseases. Those with no syndrome associated would present with neutropenia, either severe congenital neutropenia, or sometimes it could be some sort of acyclic neutropenia. And the syndromes include elastase deficiency. So elastase deficiency is the name of the disease. SCN1 is severe congenital neutropenia type 1, and ELANE is the gene affected. Similarly, with HAX1 deficiency or Costman disease is also known as severe congenital neutropenia type 3, and the gene affected, as you can see here in bold italics, although this is not italicized, is HAX1. Right. Yeah, and this is the other half of the functional, which represents the functional defects, again divided into syndromic functional defects and non-syndromic functional defects. Among the most important syndromic functional defects are the leukocyte adhesion defects, which we'll hear about, and the CGD comes under the non-syndromic defects. Now, I would like to conclude by hoping to have reviewed or overviewed phagocytosis and other aspects of phagocyte functions and defects. I would like to remind you of our level 1 Med-A project classification of PIDs, and I would like to have clarified how the IUIS and phenotypic classification documents work. And before I leave, I would like to send some messages that PIDs in Africa are underreported. We have less than 2% reporting of an estimate of 500 to 100,000 to 900,000 patients, but no patient deserves no care. So please be more diligent with spare presentations of any infection, and we need to be proactive about finding these patients and aware of how they may present. Use the available resources and improve them for better care. We need to cooperate and collaborate. We need to empower our patients with knowledge about their diseases and to encourage them in the formation of patient groups and organizations. These are very powerful in awareness, advocacy, and service provision. And finally, I would like to thank you all for being here. And I would like to acknowledge my dear friend, Dr. Rima Fiqhi, for organizing and taking the trouble of a very well formed schedule and program for this school. I also would like to acknowledge my ASID board colleagues for their support, and Mr. Omar Azraq for his excellent organization, and our wonderful patients also for their patience and the opportunity they give us to understand how their conditions work, and for their patients for us to understand that. Finally, please remember to register online. A survey will be sent 3 days after the school. If you solve that, you will get a certificate. And always use the YouTube chat to post your questions. Thank you very much. Thank you.
Okay, thank you so much, Nahla, for this excellent introduction to the topic and going through the classification. And we will certainly have questions about that at the end of this session. So in the interest of time, we will keep all questions at the end of this first session for all speakers. So now it's time to introduce our colleague from Sudan. Ryan is MD, and she's clinical immunology specialist, immunology and allergy clinic at Soba University Hospital at Khartoum. I know that Ryan is also now a research fellow at the University of Brescia. So the floor is yours, Ryan. She will talk about pathogens in patients with phagocytic defects. Thanks.
Hello, everyone. This is such a great opportunity to be joining you today. I am Rayan Joda. I am a Sudanese clinical immunology specialist. Currently, I am with the University of Brescia as a research fellow. And I would like to speak to you today about pathogens in different inherited phagocytic disorders. Key messages about this presentation, I would focus on, I would be focusing on the certain phagocytic defects, because as we all know, this school would focus on a few of the many phagocytic defects as mentioned already by Dr. Nahla. The main message in my presentation is to try to direct you all to the certain key infections that might direct you to diagnose patients with possible phagocytic defects. All infections in general are super common as a presentation of the different phagocytic defects and other inborn errors of immunity. However, these patients can also present with other features of hyperinflammation and autoimmunity. And also, please do remember that phagocytic defects can also be associated with other inborn errors of immunity, such as in combined immunodeficiencies, diseases of immune dysregulation, and A-gamma globulinemia. As mentioned by my previous in the previous talk by my colleague, Dr. Nahla, phagocytic defects can be either defects in the number and function, or pure functional defects, such as in neutropenia, severe congenital neutropenia, and cyclical neutropenia, and syndrome-associated phagocytic defects, non-syndrome associated phagocytic defects. And on the other end, we have the syndrome-associated phagocytic defects, such as in cystic fibrosis, juvenile periodontitis, leukocyte adhesion defects. And then we have CGD and GATA2 deficiencies. Infections and pathogens in phagocytic defects can be can present in most phagocytic defects. Let's put it this way: most phagocytic deficiencies can present with recurrent and severe infections, in the sense that they can be fungal infections, bacterial infections, or more importantly, mycobacterial infections. The most common fungal infections that we might see in these patients are candidal infections and aspergillus infections. Bacterial infections, most commonly, we will find patients presenting with chronic recurrent staph aureus infections, Pseudomonas, Nocardia, and Salmonella typhi infections. And mycobacterial infections, especially in Africa, we have a lot of tuberculous mycobacterial infections as an endemic region, and but we should not forget about the non-tuberculous mycobacterial infections, especially in cases of CGD. Most commonly in phagocytic functional defects, patients would present with recurrent respiratory tract infections, lymphadenitis, and skin infections, and deep tissue abscesses, and also skin abscesses. The disease-specific presentations can also be associated with granuloma formation and or inflammatory bowel disease as an hyperinflammation presentation, as well as other presentations in Barth syndrome, in G6P deficiency, and so on, and in Cohen syndrome. Most primary phagocytic disorders are diagnosed in infancy, but please do remember that some patients would present in adulthood. Primary phagocytic defects, why do patients develop these infections? Most likely, this was well covered by the previous talk, but usually patients don't have either enough numbers of phagocytes, or they have poor defective function, meaning all phagocytes cannot do their function in a way of intracellular killing, basically. We have extrinsic defects. This is usually due to opsonic abnormalities, secondary to deficiencies of antibody and complement factors. This can be seen in mostly acquired conditions such as in diabetes mellitus or in autoimmune neutropenia. Intrinsic disorders of granulocytes, these are defects in granulocyte development and granulocyte development or exit into the circulation, granulocyte killing abilities, and or chemotaxis, which is cell movement. Intrinsic disorders of phagocyte killing, this is as in CGD, glycogen storage disease type 1B, Chidiac-Higashi syndrome, and neutrophil-specific granule deficiency. Other intrinsic disorders that might be associated with other factors or other inborn errors of immunity are associated with hyper-IgE syndrome, which are defects in hypomorphic defects of STAT3 deficiencies, as well as leukocyte adhesion deficiencies and syndromes with periodontitis. Common infections in patients with neutropenia, mainly congenital neutropenia and cyclic neutropenia. We have the famous Staph aureus infections and Pseudomonas aeruginosa. In neutropenic patients, most commonly we will find Pseudomonas aeruginosa in about 13.8%, or Klebsiella, E. coli, Acinetobacter, and so on, mostly all gram-negative organisms. In patients with cyclic neutropenia, the greatest risk of death in these patients is in necrotizing enterocolitis, peritonitis, or sepsis due to E. coli or cholestridiosis due to Clostridium species. Meanwhile, in leukocyte adhesion defects, we have three types of leukocyte adhesion defects. In type 1, patients usually present with recurrent severe infections, usually localized to the skin, to the gums, and the lungs. They usually present early, and it's due to CD18 deficiency. LAD2, we have high susceptibility towards bacterial infection, and in LAD3 we have severe recurrent bacterial infections, similar to type 1, which is this will be fully uncovered in the coming sessions. Today, patients usually also present with osteoporosis-like bone features and profound adhesion and spreading defects in the bone resorbing osteoclasts. Commonest infections in these patients include Staph aureus, Pseudomonas, and Klebsiella. However, fungal infections are also prevalent. To come to speak to you about one of the most difficult phagocytic defects regarding the infectious aspect. In patients with CGD or chronic granulomatous disease, we have abnormal oxidative burst due to defective production of oxygen-free radicals, or NADPH. In this disease, even toll-like receptor pathways and signaling are affected, and this can contribute to so many other features of hyperinflammation and so on and so forth. These patients are particularly prone to develop recurrent bacterial infections, mycobacterial infections, and fungal infections. Inflammatory complications in these patients are also noted, such as colitis and non-infective granulomas. and other complications. To focus specifically in infections in CGD, we find that the most prevalent infections are gram-positive bacteria, which accounts for about 40% of patients. The most common is the Staph aureus, which occurs in about half of the patients during half of their presentation. We have also gram-negative bacteria such as E. coli, Klebsiella, Salmonella, Burkholderia cepacia infection, nocardia, and also mycobacterial infections. Fungal infections are very prevalent, as well as recently viral infections, especially with SARS-CoV-2 infection. I will try to focus mainly, these infections are not only prevalent in chronic granulomatous disease, but also in other phagocytic, inherited phagocytic defects. I will focus mainly on Staph aureus infection, B. cepacia infections, Aspergillus, and mycobacterial infections, as well as the nocardia infections. Patients with chronic granulomatous disease, they usually present with also small bone osteomyelitis or abscesses due to serratia mersens, septicemia, or B. cepacia abscesses. Recently, with the pandemic of SARS-CoV-2 infection, it was noticed that in patients with inborn errors of immunity, patients with CGD were the most affected, in the sense specifically in patients with severe COVID-19, and a large number of these patients, however, unfortunately have succumbed to this infection. An important reminder, CGD carriers usually are asymptomatic. However, some of these patients would develop severe infections, especially late on in life, apart from their hyperinflammatory presentations, such as in they tend to develop cutaneous lupus or cutaneous discoid lupus and other features of hyperinflammation. Some of these carriers do tend to develop severe infections due to the lower percentage of properly functioning neutrophils, despite them being carriers. Staph aureus, to come to speak to you about Staph aureus infections, it's Staph aureus organism and infections. It's a gram-positive organism. It is by far the commonest cause of respiratory infections, skin infections, and lymphadenitis in patients with phagocytic disorders. It causes recurrent skin abscesses, even deep tissue abscesses, such as liver abscesses, brain abscesses, especially in CGD patients. It can lead to severe persistent chronic infections and sepsis. That's why we all need to liaise locally with our microbiology units to properly screen and employ certain guidelines in order to properly monitor our patients and prevent and treat these infections. To come to speak to you about B. cepacia infections, patients usually present with this infection with septicemia and abscesses, especially in CGD patients. It's a gram-negative bacteria. Moving on, we have nocardia species. This has been reported a lot of times in patients, especially in patients with CGD. It's a gram-positive, catalase-positive organism. Infections usually are characterized by pneumonia, skin diseases, or often disseminated nocardosis. Inborn errors of immunity that patients with inborn errors of immunity that tend to develop CGD, tend to develop nocardia infections are CGD patients, patients with even hypogammaglobulinemia, combined immunodeficiencies, CVID, hyper-IgE, and patients with Mendelian susceptibility to mycobacterial diseases. The classical presentation is usually a pulmonary infection with cough, fever, dyspnea, and chest pains. Radiological imaging will show either focal or multifocal infiltrates and even pleural effusion. However, in some patients, especially in patients with inborn errors of immunity, we may find either disseminated nocardiosis or infection or cutaneous manifestations such as mycetoma. And in patients who tend to be immunocompromised, or in our case, patients with inborn errors of immunity, we can find that nocardia can present as either with ocular manifestations that often disseminate into systemic disease, or CNS manifestations and infections. The treatments are usually with Septrin, amikacin, or others as a primary treatment, or in combination with other a combination therapy with other antibiotics such as dapsone, amikacin, and linezolid antibiotics. To come to speak to you about fungal infections, we have the most common is Aspergillus infection. This is usually prevalent in all inborn errors of immunity, especially combined inborn errors of immunity. But however, in patients with chronic granulomatous disease, it's second to Staph aureus infections. It comes second as the most common cause of pneumonia in these patients. We also have candidal infections. Some patients can tend to develop systemic candidiasis, severe oral or even genital candidiasis, or even severe gastrointestinal features of candidiasis, such as esophageal candidiasis. I want to focus more on mycobacterial infections, especially atypical mycobacteria, or as we all know, environmental mycobacterial infections, because in Africa, most patients who would be susceptible to a diagnosis of, for example, chronic granulomatous disease, these patients would present with a mycobacterial infection, most often tuberculous mycobacterial infection, as their first presentation of CGD. But atypical mycobacteria is also present, such as patients might be infected with Mycobacterial avium complex or mycobacterial abscesses. Mycobacterial disease penetrance in patients with CGD is incomplete, in a sense that patients would develop with BCG adenitis or even with BCGosis, which is systemic BCG infection. Patients with hypomorphic mutations in CYBB gene tend to have been found to cause MSMD, which is Mendelian susceptibility to mycobacterial diseases. And this is very interesting in a sense that CYBB gene deficiency is associated with chronic granulomatous disease. I would like to conclude my talk by recommending regular screening of all patients in your clinic is key, with the proper usage of prophylactic antibiotic. Regular screening, meaning when we say regular screening, we have to do regular screening, urine screening, skin swabs, stools, and sputum. All of this depending on the patient's usual presentations, usual complaints, manifestations, and clinical status. Always screen for mycobacterial infections, not only specifically Mycobacterium tuberculosis, but not only for Mycobacterium tuberculosis. Please do implement staff carriage screenings and treatment protocols in your clinic. They are very helpful, and it will significantly limit the patient suffering. And IIE patients with autoimmune or autoinflammatory conditions in association with their main manifestations, either in phagocytic defects or other inborn errors in immunity, require close monitoring because they will be on further immunosuppressive agents. Thank you very much.
Thank you, Dr. Ryan, for your very elaborate presentation on pathogens affecting patients with phagocytic disorders. And now I'd like to introduce Professor David Goldblatt. He's a consultant pediatric immunologist at Great Ormond Street Hospital and professor of vaccinology and immunology and head of the immunobiology unit at the Institute of Child Health, University College London.
Well, thank you very much for inviting me to give this talk today. I'm going to focus on chronic granulomatous disease, and I'm going to describe the disease all the way from pathophysiology through to the treatment. So first of all, just a little bit of history. The disease was first described in the 1950s and was considered fatal, as all the children who were investigated and identified all died. They were tended to be boys, large livers and spleens. They had lymph node infections. They used to get very bad lungs and then an early death. And it was in the 1960s that Queen Holmes, working in Minnesota, identified the fact that there was a defective intracellular killing of Staph aureus. And if you look at the electron microscope here, you'll see that magnified are these vacuoles with a V to indicate what they are. And these are the vacuoles when a neutrophil or phagocytic cell phagocytoses foreign material. This is where the foreign material ends up. And the Staph aureus, in this case, in those experiments, could get into the vacuole, but they could not be killed. And we know today that the vacuole, in the wall of the vacuole, are two proteins, which are made up of a 22 kilodalton and a 91 kilodalton molecule, and that there are also several proteins that are in the cytoplasm of the cell that together will come together when there's a stimulus in the vacuole to generate superoxides, and this is called the NADPH oxidase. And so what happens when, let's say, Staph aureus is, and normal situations gets into a vacuole, is these molecules come together and electrons are transferred through this into the cytoplasm of the cell, into the vacuole, and there you can see that you get hydrogen peroxide produced. Now, in the past, we used to think that this hydrogen peroxide was itself intrinsically toxic to the bacteria or the fungi that were inside the cell. But now, because of the work of Tony Siegel, we understand that, in fact, the major impact of this electron influx is that it increases the pH. And when it increases the pH, there are already enzymes that are present in the vacuole that are inactive at acid pH. And as soon as the pH starts going up, these enzymes become active, and whatever is inside that vacuole is destroyed by the proteolytic enzymes. In CGD, however, because you don't get that electron transfer, the pH remains low, in other words, remains acidic, and therefore the enzymes remain insoluble, and so killing and digestion are impaired. And this obviously has a major significance, which you will see when we discuss the consequences of the absence of this functioning NADPH oxidase. So, as I pointed out, these number of proteins are available, are part of the NADPH oxidase, and therefore, when you look at the genetic forms of CGD, where one of these proteins is absent, you can see that really all the proteins that I've mentioned here have been described in one form or another where they're absent. This is the gene designation, and this is where they are on the chromosome, and then this is an inheritance. So historically, we've always thought of the fact that X-linked disease is about 70% of individuals, and that the autosomal recessives make up the other 30%. However, this isn't always necessarily the case, and that's partly because a lot of this work has been dominated by research that's been done either in North America or in Europe. So too has the emphasis on the incidence of the disease. And here you can see the estimates between 1 in 125,000 and 1 in 200,000 or 250,000 children born have CGD. But as we've learned more about the disease from parts of the world that are not necessarily just in Europe or South America or North America, we do get a slightly different picture of the patterns of CGD. And this is a study from India, which was published in 2021, and it looks at 251 patients. And what you can see is that of the patients where a molecular diagnosis was made, there were 77 with X-linked CGD and 97 with autosomal recessive CGD. So the percentages are rather different here in this type of setting in India, although of course not all the patients had a molecular diagnosis, so perhaps we need to be a little bit careful. However, if we do look at other studies from parts of the world, we can see that this split, where there's in fact more autosomal recessive and less X-linked CGD, is replicated. So here are 3 studies, one from Turkey, where there were 56% autosomal recessive and 38% X-linked, fairly small study. Also a relatively small study in Israel, where 62% were autosomal recessive and 38% were X-linked. And of the autosomal recessives, about 2/3 of them were from consanguineous families. And then a study from Saudi Arabia, where the 100% of the patients were autosomal recessive. There were no X-linked, but again, a small study. And the references for these studies are here in the colored writing below. Also in Saudi Arabia, you can see the incidence was 5.2 per 100,000, which is quite a bit more than the 1 per 125,000 to 1 in 250,000 that I mentioned earlier. So we do need to consider whether perhaps this CGD might be slightly more common in some parts of the world than it is in others. But we need more large studies from these types of countries and regions to really understand fully the potential overall burden and molecular basis of chronic granulomatous disease. Now, I'm not going to talk much about the diagnosis because Kimberly Gilmore is going to give you a talk on that, and she's going to talk about how to make the diagnosis of CGD. I'll just say that for us, the gold standard is NBT because we have a very experienced laboratory, but many laboratories will make the diagnosis using an assay, which is flow cytometric based. Once you make the diagnosis, you want to know which of the oxidase proteins are missing. You can do this by Western blotting or flow cytometry. Again, Kimberly will explain this in detail. And then, of course, one wants to know what the genetic basis of the disease is. And so all of our patients who, as soon as they are diagnosed, we have DNA sent away for the mutation analysis. Now, particularly for X-linked, the X-linked gene for CGD lies here, just between retinitis pigmentosa and very close to Duchenne's muscular dystrophy. And there were some very famous patients in the past who had large deletions of their gene for X-linked CGD and also had retinitis pigmentosa or muscular dystrophy. And the other thing just to say in passing is that there's also the gene that codes for the KEL glycoprotein is also close to here. So if you see boys with X-linked CGD with large deletions, you need to be a little bit careful that they don't have McLeod's phenotype as well, which is a problem when it comes to red cell red cell transfusions because they tend to lyse very quickly. So just mainly pointing out that with deletions, you can get other diseases that can give you perhaps a clue and were very important in establishing the molecular basis of CGD historically. Now, we tend to think that there must be a very simple phenotype-genotype correlation, but I just want to illustrate with this pair of boys that that's very different because they come from the same kindred. They've both got X-linked CGD. Sadly, he has died from very severe lung disease while he's hardly ever had any infections in his life and have exactly the same mutation. So there are many, many other genes in the immune system that are able to impact on immunity. And so just having a particular mutation of DNA doesn't particularly mean you're going to behave in the same, necessarily in exactly the same way. So the major kind of clinical manifestation of CGD, as I've already hinted, is infection. Under normal circumstances, you get infection followed by phagocytosis. In CGD, you don't get resolution of the infection because the bacteria or fungi are not necessarily killed. This means you can get end organ involvement and you'll see infections in the skin, the lung, the bone, and the liver, amongst others. So when you look at factors that lead to the very first diagnosis of CGD, you're not surprised to see that a suppurative lymph node infection or abscesses in general are the ones that you see most commonly. And this is just from a review that from our experience that we published in the UK. Obviously, in tertiary centers of family history is very important because you tend to look after families, and then you can see the other forms of infection that are common. So the most common is probably perianal abscesses, or one of the very common manifestations, because of course you have a lot of bacteria in this area. So it's very, very common for children to present with perianal abscesses. Abscesses in the folds of the skin, which are warm and moist where bacteria can thrive, are also quite common. And here you can see kind of an inflammatory response to the Staph aureus in the skin. Mouth ulcers are pathognomonic. Not entirely sure what the role of bacteria are here, but very, very common in CGD, and also very common in the carriers of CGD. And then this is the kind of lymphadenitis and the kind of complication you can have where these lymph nodes can burst through the skin. And they can take a long time to heal and may need incision and drainage. And of course, what we fear is this type of infection where this is a liver abscesses, and you can see here there's involvement of the rib as well. So you'd think that with such a kind of propensity to infection, that if you looked at a group of patients with recurrent severe pyogenic infections, you'd see lots and lots of CGD. Well, that isn't necessarily true because abscesses, of course, are not uncommon. And this is a Israeli database of almost 1,300 patients over 25 years referred because of recurrent severe pyogenic infections. And you can see that CGD was diagnosed in about 4%. So depending on your perspective, that might be a lot or might be a little. But it just shows you that you will investigate a lot of patients with recurrent infections before you find one with CGD. The infection we really fear the most is illustrated by this chest X-ray here, which shows a fluffy picture, which is typical of a fungus, and this is Aspergillus. And we are very, very concerned about Aspergillus infections, although we have much better antifungals now, which can help us treat it. And the problem with Aspergillus is it eats away at bone, and also in this particular patient, threatened to eat away into the heart as well, because it destroys tissue. And so this remains a very great concern in patients with CGD, Aspergillus infection. This is a table showing you the pathogens in CGD. You can see Staph aureus is very common and causes lots of different clinical manifestations. Burkholderia, Serratia, Leucardia, Aspergillus species. And you can see some of the more unusual or rare conditions. But it is important to point out that some of these pathogens are really quite geographically distinct. And so, for example, if you look at patterns of CGD from the literature, you'll see that here in North America, this is what they tend to describe. Here in Europe, this is what we tend to describe. And if you look in series from Hong Kong, you'll see lots of mycobacteria, as you will in South America as well. And then here in the Middle East, you tend to get reports of Leishmania. So depending on where you are practicing and living, you may well have a different pattern of presentation. And of course, with mycobacteria, also there's the risk of disseminated BCGiosis. And so in those parts of the world where you're giving PCG regularly to newborn babies, you may well see more BCGiosis than you would perhaps in the UK or in the USA. Now, this is a series we did looking at 10 years of experience with CGD. And when you look at presentation, you can see that lots of the patients have infectious complications. But when you look at follow-up, you see that a lot of patients have this complication of, which are essentially manifestations of different forms of inflammation. So this is a picture of a gut biopsy in a child with CGD, and very typical. First of all, you can see some eosinophils here in the gut, and particularly you can see these large pigmented macrophages that have lots of very dark purple pigments. And this is an example of these macrophages which have digested or taken in probably cells that have died by apoptosis but haven't been able to digest them. This is very typical, together with abscesses, of the colitis in CGD. And the colonoscopy may be macroscopically normal. So biopsies are very, very important, because a lot of the CGD patients will have some gut problems, but they could also be subclinical. And when you look, the specific features are, compared to particularly Crohn's or other types of inflammatory bowel disease, are apparent paucity of neutrophils, eosinophilic inflammatory infiltrates, these large pigment-containing macrophages, and then granulomas, which are generally more prominent and more prolific with macrophages than you see in Crohn's. And the classical treatment is sulfasalazine and steroids, together with some other modalities, and I'll say a little bit more about some of the biologicals towards the end of the talk. Now, in the last 10, 15 years, we've become aware that for some forms of CGD, the colitis is, in fact, the dominant clinical presentation. And here's just an example of 3 girls that come from the same consanguineous family. 2 of them had a diagnosis of Crohn's disease. They didn't get many infections and were being looked after by gastroenterologists, but they were part of a genetic study which happened to show that they have the CYBA abnormality. In other words, an abnormality in the gene which codes for P22. And on further exploration, they were indeed homozygous for these mutations in P22. And when you looked at their ability to produce superoxide, you could see it was reduced in the patients, which are red, compared to controls. And this is just an amplex red assay. Some people used dihydrorhodamine and others, but they also have a monoclonal antibody called 7D5, which showed a normal binding to control cells, but abnormal binding to the 2 patients. And 7D5 recognizes a conformational epitope, which is made up by GP91 and P22 binding together. So in other words, this patient's had abnormal P22, so they didn't have the 7D5 antigen, which could be detected by this monoclonal antibody. And these patients, as I said, 2 of the girls predominantly had colitis with no infection. So that has also led to people wondering whether it would be useful for patients with inflammatory bowel disease to all be screened for chronic granulomatous disease. And this is what this team did at Columbus, Ohio. They looked at all the individuals who were between 12 months and 21 years of age, but who did not have CGD, but had a diagnosis of inflammatory bowel disease. You can see they screened 120 by dihydrorhodamine flow, in other words, a flow cytometric assay for CGD, 76% had Crohn's, 90% of ulcerative colitis, and 5% were intermediate. And 30% actually did report a history of infection. And so you may or may not be surprised, but when they looked at the results of this CGD testing in this inflammatory bowel cohort, none were diagnosed with CGD. So it's relatively the same kind of issue as I showed you with the infection registry in Israel. It's relatively rare, and so you might not expect to find out of 120 patients with inflammatory bowel disease, one with CGD. So that's not a good way of looking. You need to be more, perhaps clinically astute to try and recognize those with CGD. So we've done the infection part, and you see the bacteria here that cause the infection, non-resolution. But equally important is phagocytic cells are important in terms of dealing with cells that have died or necrotic. They are phagocytosed and usually are taken out of the circulation by these cells which deal with them. But in CGD, there's again non-resolution inflammation and granular formation. And again, this can also impact on many, many organs in the body. And so we now know that there's an enhanced inflammatory response in cells that are from individuals with CGD. And in this work from David Speart's lab in Canada, what you can see is that CGD in the gray produces more IL-6 than control neutrophils and produces more TNF-alpha than control neutrophils. And this leads to a form of hyperinflammation, which is now very well recognized. So you aren't able to shut down inflammation well enough, and therefore you get hyperinflammation. And the clinical manifestations are you can get granulomas in the walls of hollow organs. Here you can see a large space-occupying lesion in an old barium swallow picture, which is perhaps a little bit historical now. You can also, if you have good eyesight, notice that the slightly thickened bowel wall, and then after treatment with steroids, because these tend to be very sensitive to steroids, you can see there's a normal now peristaltic wave in the esophagus. We used to see a lot of gastric outlet obstruction, again, because of granulomas in the wall of the stomach here in the antrum, preventing the smooth passage of food from the gut, from the stomach into the duodenum. Again, responsive to steroids. And then particularly in the bladder also, very thickened bladder wall here, and a child presenting with really very extreme difficulty in passing urine. And these are exquisitely sensitive to steroids. You can give steroids, and within 3 or 4 hours, these children have huge relief from their inability to pass urine. So these are, again, in a sense, historical pictures, but you will encounter in the CGD cohort these complications. And then also, if you look in the eyes of children, you'll see that they can have these punched out lesions, which look like toxoplasmosis, but we've never been able to find a bacterial or viral or toxoplasmosis-like cause of these. These would appear to be clusters of cells that are illustrating, or now dead, but illustrating some difficulty in managing with inflammation. This was a paper we published many years ago, and we happened to find these were all children with X-linked disease, but there have been several other papers now in the literature which show that both children with X-linked and autosomal recessive disease do get these eye manifestations of CGD. Now, interestingly, we also found some carriers with these types of manifestations. And so X-linked CGD carriers can have clinical manifestations that are very important. And so here, again, is a study that we did at Great Ormond Street looking at some of the clinical manifestations of CGD in carriers. And what you can see is that they have cutaneous and other lupus-like symptoms. And in this prospective study, we found that almost 60% of the mums had skin rashes, almost half had mouth ulcers, and they had joint pains. But importantly, they were anti-nuclear antibody negative. So we failed to get our rheumatologists, our adult rheumatologists, interested at this stage in these patients because they were negative in terms of anti-nuclear antibodies. So negative lupus serology makes it difficult to get a referral, but should not exclude specialist referral. And there's a lot more work that's been done, particularly here in the UK, on carriers now. And a lot of the carriers also have quite a lot of gut symptoms. So here you can see that 50% of the carriers in this quite large study had GI symptoms, abdominal pain, diarrhea, and rectal bleeding. Not what you would usually associate with carrier status, but when you begin to look for these, you find that they do have these issues. And here you can see also photosensitivity oral ulcers, Raynaud phenomenon, and joint symptoms, including fatigue. And this leads to quite a significant degree of depression. And we've done a health-related quality of life for these carriers, and we find that the mothers who have CGD are not as good in terms of their physical function and not as good in terms of their general health, and particularly have some emotional and mental health issues compared to normal individuals of the same age. So this is a really significant problem, and if you have lots of X-linked families in your particular area where you're practicing, you need to pay attention to the mothers as well. So outcomes in CGD, well, they used to be, as you know, we said uniformly fatal from the initial slide I showed. It was described in 1957, and the initial overall mortality from studies in the 1970s was about 50%. Mortality started going down if you look at studies that covered periods from the 1950s to 1987, and then a registry was established in the US where the overall mortality was now said to be about almost 18%. A Japanese one, 23%, and then German, and then a more modern study looking at mortality in the UK of 9%. And so what you actually see in that as you look at actuarial survival, you can see that historically, when you look at a large cohort of patients, these are the survival at these different years of age. And of course, this type of survival pattern covers a very large period of time before we began to see the optimization of therapy. So we've had a huge advance in CGD therapies over the years, which has changed quite significantly this natural history. This was a nice review of the chronic granulomatous disease European experience and the survival of CGD patients historically over time. And you can see that historically there has been a suggestion that the autosomal recessives are milder in terms of clinical situation than the X-linked, and therefore did better over time. However, with more modern experience, I can tell you we do see some autosomal recessive patients that have very severe disease and some X-linked patients that have very mild disease. So it's not entirely clear to me now that we have very, quick therapies that we initiate as soon as we make a diagnosis. It's not entirely clear to me that this distinction between autosomal recessive and X-linked is still quite as clear as you see on this particular slide. But the main thing, I suppose, is that there's been an evolution in CGD care, described in the 1950s. So, of course, increased awareness and earlier diagnosis. Having said that, I still think a lot of children will get sick and perhaps even die without the diagnosis ever being made. Septum prophylaxis was introduced in the late 60s, early 70s, and is now very, very widely used. And this has obviously been a really, really important component of therapy of CGD. Aggressive management of infection is now pretty standard wherever you have physicians aware of CGD and its complications. Antifungal prophylaxis has been hugely important in trying to prevent what was often a fatal fungal infection, particularly with Aspergillus. And not only that, but we've also had new antifungals now that are much easier to give to patients, many more oral formulations, which have made a transformation of the ability to treat patients with CGD. In some parts of the world, particularly in the US, interferon gamma therapy as a prophylaxis was used, or used perhaps as an adjunct to infection management in other parts of the world. We've never really used it for prophylaxis in Europe, but they have in North America, and that's probably also added to prevention of infection. As I mentioned, the new generation antifungals are very, very important, as are the anti-inflammatories that have now come along and are helped to treat the biologicals that are helped to treat the colitis. So overall, there's been much improved survival and a better quality of life because of all these changes over time. And of course, the Holy Grail has been cure, and there's been enormous strides taken over the last 15 to 20 years in the bone marrow transplant. It's really transformed the management of CGD, and Reem Feki is going to tell you about that in the last talk in today's symposium. So our current approach here at Great Ormond Street is that we initiate antibacterial and fungal prophylaxis as soon as we make the diagnosis, and we monitor compliance. We get a molecular diagnosis as soon as we have confirmed that CGD is the disease and that the proteins are absent. We immediately tissue type and search for a donor. We have, of course, large bone marrow registries where we'll search for unrelated donors, and we screen the family for a matched sibling donor. And we transplant early if a donor is available. So pretty much as soon as we made the diagnosis, and we don't wait to see what their clinical course is, and we don't make a distinction between autosomal recessive and X-linked. We will transplant a patient who's proven to have CGD if they have a matched related donor, a matched sibling donor, or matched unrelated donor. While we're waiting to find this out, we manage pyrexia of unknown origin very aggressively. And in certain situations, if an X-linked CGD patient does not have a donor available, but is potentially sick, we do explore a gene therapy. We've used this in a number of patients, which Dr. Alfeki will probably review for you, and often used as a bridge to transplant, because we may have, particularly in the situation of aspergillus, we may have an infection that's difficult to manage. And as I mentioned earlier, we manage carriers proactively if symptomatic, because a lot of them are symptomatic and a lot of them have a relatively poor quality of life. And the key thing is that we have, looking after patients with CGD is very much of a team approach. We have, first of all, a CGD trust or society that provides funding and supports particularly a clinical nurse specialist, who's at the moment Helen Brangens at Great Ormond Street, who's really, really critical. We have a very responsive laboratory, and you're going to hear from Kimberly about the diagnosis of CGD. And of course, we have other expert groupings in the country, particularly in Newcastle, where they have a lot of expertise in bone marrow transplantation. So it's a real team effort together with the children and their parents to look after patients with CGD. Thank you very much.
in some of these patients. So it is a very complicated process, I would say.
Right. Thank you. The second question is about primary phagocytic disorders being disorders or diseases of childhood. How to explain or investigate an adult male that shows features of CGD?
I would say that we can dig into the patient's past history. We have to know their exact clinical manifestations, and we have to have the suspicion that he might be a patient who would have a phagocytic functional defect. But in terms of the actual diagnostic approach, it's basically the same as in children. Yes.
All right, thank you so much. The next question is for Professor Goldblatt. Thank you for your excellent presentation. The question is about you mentioning the anti-inflammatory biologicals. Are they only for those with IBD? If not, what do you use?
Okay, thank you. Thanks, and thanks for inviting me to speak. Just a few comments maybe about the other questions.
Okay.
As I pointed out in my talk, the carriers of CGD also develop autoimmune phenomena like lupus, discoid lupus. Exactly. So, and remember, those are generally healthy women who don't have major problems with any other part of the immune system. They have a very, very specific component of their immune system that's abnormal, and they're carriers. So only a proportion of their cells will be abnormal. And so the question is, well, what is the pathogenesis of autoimmune phenomena in those particular individuals? And so what we know is that even if only, let's say, 50% of your cells are normal and 50% of your phagocytic cells are abnormal, because they can't deal with apoptotic cells, which is a very important function of phagocytic cells, they do start generating local areas of inflammation. And so it's a clue that part of the manifestation of autoimmunity is an inability to control inflammation. In this case, it is stimulated by perhaps bacteria, but more commonly by apoptosing cells, which are then phagocytosed. And so if these women can get discoid lupus or systemic lupus, as some of them do, it must be related to the fact that even just a small component of the immune system is unable to satisfactorily get rid of cells and control inflammation. So I think it's quite a clue to the origins of autoimmunity. The second question about how can adults, have CGD if they've grown up through childhood and no one's recognized it? Well, of course, not all patients with CGD have an absolute deficiency and inability to develop and generate a reactive oxygen species. So there are some forms of CGD where you are able to produce a little bit of NADPH oxidase, and you are able to reduce a little bit of, in other words, you have some normal function. And sometimes we refer to those as hypomorphic. And so there's a very nice series in The Lancet from many years ago where patients were only diagnosed as CGD in their late teens or early 20s. And many of them had these partial defects. So it was not a complete absence of the protein responsible, which is part of the NADPH oxidase, but perhaps they were producing normal amounts of protein, but the protein wasn't functioning properly, or they were producing very small amounts of protein that were helping the NADPH oxidase. So that's why it's quite a complicated picture, and that's why you can get manifestations of CGD only diagnosing in late adolescence, early teens, sometimes even 30, 40-year-old people. So that's why it's not really one disease, it's quite a spectrum. Finally, the question about the biologics, which is what you actually asked me to talk about, a lot of the development of the biologics has been around inflammatory bowel disease. Remember, in CGD, there are very few patients compared to the number of patients with inflammatory bowel disease. So when there was a lot of excitement about the anti-TNF molecules, such as infliximab, when they showed good evidence of working in inflammatory bowel disease, they were tried in CGD. And Steve Holland actually did a really nice evaluation of the benefit of infliximab in CGD. And while they do provide some relief to some patients, the problem is that they are also associated with a susceptibility to opportunistic infections. So in Steve's very nice paper, he warns that if you are going to give a patient with CGD infliximab, you need to be very careful about monitoring them for infections, and particularly making sure they don't have TB before you start, because you can get, TB can flare up. So But infliximab is not a cure-all, and many of our patients have an initial response and then disappointing. So we've also used adalimumab, which of course is the humanized form of infliximab, and that too is sometimes promising, but doesn't provide long-term relief. There have been some studies in CGD of anakinra, which, as you know, is a molecule that is an IL-1 receptor antagonist, and that too has helped some patients, but really not provided a particularly good relief over a long period of time. And finally, people have now been trying, and again, Steve Holland was evaluating a molecule called ustekinumab, which is an antagonist of IL-12 and IL-23. And the difficulty with these is that there aren't enough CGD patients to do big clinical trials. So generally what's being published is small series of individuals using these biologics with some partial response, but really not a very good response. So overall, I'd say it's been a bit disappointing to see how the biologics function in CGD. Thank you.
Okay. Hello?
That's
Okay, do you hear me?
Yeah.
Okay, so we have few more questions. One is about anti-TNF, but I think that you just mentioned Dr. David Goldblatt. Do you want to elaborate on anti-TNF treatment of CGD more than that?
Well, this question actually is about interferon gamma. And they're asking me, what is the current place of using interferon gamma in treating infections in CGD? So as I mentioned, there's it's kind of culturally a little bit different about the use of interferon gamma. It was used as prophylaxis in the US. So in other words, maybe twice a month or once a month getting injection of interferon gamma to try and prevent infections. We've never used that in Europe consistently. We do occasionally use it when we have, for instance, let's say liver abscesses, which are difficult to treat and the patients are very symptomatic with lots of fevers. We will sometimes use interferon gamma as well. But I must say, for the last probably 5-10 years, I don't think I've used interferon gamma like that. I did use it historically. I'm not sure what other groups around Europe and North America are doing with interferon gamma at the moment. Thank you. Back to you.
So, may I have another question for you, please? So you mentioned earlier that probably in our region, in this region of the world, and we have some data, although they are preliminary, showing that we have many more autosomal recessive forms of CGD than X-linked forms.
Yes.
So what about the severity, comparative severity between X-linked and autosomal recessive? Is it only due to the residual presence of the superoxide production, or could it be linked to the type of gene which is affected among the six we know, or mutation, the type of mutation? What is your evaluation of this aspect of correlation between phenotype and the genotype?
Well, I think
in terms of severity.
Yeah, so I think historically, as you saw from the European slides, there did seem to be this suggestion that autosomal recessive was milder. As I said in my talk, our experience here in the UK is that we have a number of autosomal recessive patients that have as severe disease as X-linked. So we really do not treat them differently anymore because we have seen very, very severe outcomes for patients with autosomal recessive CGD, which includes lots and lots of problems, abscesses, fistulas, end organ disease, and of course, patients dying from various infections. So that's the first thing to say is I'm not sure there is really a difference, and it might have been a bias just in terms of how the studies were set up and the acquisition. If you were thinking about a biological explanation, and what you mentioned was that maybe some of the autosomal recessive patients have some residual activity, well, that isn't also necessarily the case because many of the autosomal recessive patients have no P47 or P67 at all, and they have a severe phenotype. I did, however, mention the P22s, which are a very special example where they do not tend to have that much infection. They mainly have inflammatory complications. And it may be that if you have a P22 deficiency, you're less likely to have fatal complications and their survival is better. So those might be biasing why we see perhaps in the early studies better survival overall. But those studies, as I shared, focused on survival. And I think when you look at quality of life, you'll find that for many of the patients with both autosomal recessive and X-linked, quality of life is poor. So in areas that are dominated by autosomal recessive disease, such as where you are, Dr. Rita, then I assume that you will see a spectrum of patients. And I think that every patient with autosomal recessive disease, if they have a complete defect, in other words, they're not producing any NADPH oxidase, they will have a severe phenotype and really should be transplanted as soon as possible. If you have patients who have some residual activity, the so-called hypermorphic patients, then of course it's a slightly more difficult because you don't know what their residual immunity is going to do. It might actually prevent them getting, for instance, fungal infection. And fungal infection is really the fatal outcome for many of our patients. So it might be that it's better that if you've got a hypermorphic patient, you don't have to necessarily jump straight to transplant. But if you have a patient who has a 0 NBT and no activity at all on the DHR, I would recommend that you start thinking about transplant early. Thank you. Back to you.
Okay, thank you so much. So that's absolutely the case even in our observation here, yes. So we are waiting for the talk by Professor Holland, who has been sent apparently. So we will wait a little bit. Omar, let us know when it is ready to go. So this, I have one more question for Ryan. What is, from the students, what is the utility of screening all mycobacterial infection as they are ubiquitous and have high prevalence? Ryan?
Yes, we have to, you have to liaise with your local microbiology units to see what is the local guidance for mycobacterial infections there, and then follow the steps. But usually you have to do regular cultures, regular PCR screenings, and so on and so forth for your patients, depending on your country of origin. That is what I can provide. As I'm not a microbiology expert, this is the basic and most, I would say, most efficient way to go by.
Yeah.
So with regard to this, sorry.
Yeah, I was just going to
Yes.
add a little bit. I mean, what we normally do is do the interferon gamma assays. These are sensitive, obviously, but I do remember having come across a patient who came with a history of with recurrent tuberculosis and leprosy, and he came with similar presentations and presented to our clinic just with the history. We did not have any data from previous studies. And what I did at the time was he had ascites. So what we have available in Sudan, for example, we have the gene expert for Mycobacterium tuberculosis. So that excludes only tuberculosis. We did the assay on the acidic fluid. We also looked for the ADA enzyme, which is again a screening method that would tell us whether the mycobacteria are present or not, as was explained to me by the microbiologist, as Ryan has mentioned. We also did the sputum, and that's samples from the ascites for both acid fast and acid alcohol fast bacilli, both on room temperature and in the incubator, because the non-acid fast bacilli, such as the atypical mycobacteria, would grow in normal temperature, and they are fast growers. So you have to check for growth a lot more quicker or more frequent than the 6 weeks, and the growth is usually done on the regular Livingston-Jensen media that's used for tuberculosis. So definitely this needs good liaison with microbiology, but there are some standard methods that can be used, I suppose, and can be helpful within our limited resources as well. Thank you. Rida, I don't know. Yep.
Can I just add something? I mean, I think what the question is really focusing on is atypical mycobacteria are ubiquitous. You can grow them from water, you can grow them from anything in the environment. And I think the question is, when you isolate an atypical mycobacteria in a patient with a primary immune deficiency, such as CGD, the question is it causal and is it related to the presentation? So we've had a number of CGD patients here with pneumonia, very difficult, we can't find a pathogen. Eventually, we will do a bronchoalveolar lavage or bronchoalveolar biopsy, and then we find that there's some atypical mycobacteria, and we have a long discussion internally about, is it causal or could it be just simply from the environment? And I think that's really difficult for all of us in this community to know.
Exactly.
We then spend a lot of time with patients on tetracyclines and other antibiotics, which can last for 6 months or a year. So it's a really, really tough conundrum clinically about whether we should or shouldn't treat. Thank you.
It's more of a diagnosis of exclusion under such circumstances and a high degree of suspicion.
Okay, so I think that Omar did let me know that the recording for the talk of Steve Holland is ready to go. Omar, do you confirm that? So. Is Steve Holland present or not? He's not connected?
Okay, there's been another question in the chat about gene therapy. I think Dr. El-Feki may deal with this, but I'll just quickly say that obviously gene therapy for CGD at the moment, it's mainly for X-linked CGD, but there are trials starting for autosomal recessive. Was published recently in Nature Medicine, and the outcome is it's not a cure yet for all CGD. It is gives some partial support for patients, but then they can lose their gene therapy cells and they go back to having the CGD phenotype. And I'm sure Dr. El-Feki will tell you more about that. So it's not a second line of treatment, but if we have a patient with very severe Aspergillus infection where we're struggling to control it and we don't have a transplant donor yet, what we can do is we can do gene therapy. This provides them with cells for enough time sometimes to get rid of the Aspergillus infection while we continue looking for a matched unrelated donor. And then eventually we find a donor and we transplant them. That's why we call that a bridge to transplant. It does work in some cases, and the literature shows you there are some individual patients who have been cured with gene therapy. But if you read the paper in Nature Medicine, I'm sure Dr. El-Feki will remind you about that. It's not 100%, so it's still an experimental therapy. Thank you very much. Back to you.
Excellent. I was thinking about the question on autoimmunity and CGD. I totally agree with what has been said. I mean, I think it's more to do with perhaps the ability to deal with apoptotic bodies as well as the chronic inflammation and all that. and that it seems to be affecting more of the the female carriers of the disease rather than the actual patients. One more thing that I remember doing whenever we come across this is we look for C2, complement C2, because there has been a strong association of the presence of C2 deficiency among patients among carriers, female carriers with CGD. And I think that was also an attribute to an additional risk of developing autoimmunity and things like photosensitivity among this group of patients. And actually, photosensitivity seems to be a sensitive marker or symptom that patients may be complaining of that would lead us to, these patients are suffering from some degree of autoimmunity and we have to deal with. Thank you.
Okay, thank you so much. Thank you to all of the speakers for their contribution and for replying to the questions from the students. I think it's time now to move to the presentation by Steve Holland. Omar?
Good morning. My name is Dr. Steve Holland, and I'm going to talk to you about leukocyte adhesion deficiency. So in 1979, Hayward and colleagues described a disease that they recognized had abnormalities of umbilical cord separation and neutrophil mobility. And what you can see here in this abstract from 43 years ago is that out of the 6 infants that they identified, 4 died. And they identified that there was defective neutrophil mobility that was responsible for this. A year later, in the United States, another group that involved investigators all over the East Coast and central US identified the same disease in a young man who traveled back and forth and realized that he had severe neutrophil chemotactic defects as well. And they published this picture. And what you see here on the right side is that a normal neutrophil should spread out and become very flat, but the patient, in fact, was unable to spread on a glass slide. In 1982, investigators in Seattle identified again the same disease and recognized that they were missing a particular cell surface glycoprotein. And what you see here is the inability of those neutrophils to stick to either glass beads or nylon wool, which were experimental conditions that were used in order to identify the ability of neutrophils to stick rather than using chemotaxis per se. And you can see here that the normals had very high rates of adhesion, whereas the patients did not. In addition, the patient cells were unable to undergo chemotaxis, to move in the direction of a chemotactic gradient. And you see here that they are very, very low compared to the normal cells listed there as percent of 100. Finally, in 1984, Don Anderson recognized this disease more definitively and published this in the Journal of Clinical Investigation. And what he realized was, number one, he had a much better camera. And so you see a much more impressive picture of a normal neutrophil spreading on a glass slide, the nucleus in the center and the cell spread out like an egg. But then you see on the left that patient cells are simply unable to do any of that. In addition, he recognized that some cell surface proteins were not evident based on flow cytometry, which was a relatively new technique at the time. And as you can see here, there is a control, CR1, in which the patient in black here expresses normal amounts of CR1, but is missing expression of LFA1, OKM1, and beta. And in today's language, we would refer to these as CD11A, CD11B, and CD18. And we know that CD18 is, in fact, the missing gene in leukocyte adhesion deficiency type 1. So what's going on? What we're really trying to understand here is how does the neutrophil get from the blood vessel on the left into the tissue and then out to breakfast? And I know you are wondering how to get to breakfast right now as well. So how does this happen? Neutrophils roll along the blood vessel. And as they roll, they're constantly sampling that blood vessel with a molecule known as CD15S or sialyl Lewis X. And that molecule is highly fucosylated. And you can see here the molecule in blue and the fucose sugars spread along its surface there as the FU. These interact with selectins on the endothelial surface and allow the neutrophil to sample the endothelium as it goes along. When the endothelium realizes that when the neutrophil realizes breakfast is about to be served, then it sticks tightly to the endothelial surface and it displays new receptors known as integrins. And you see that they all have the same CD18 molecule and different CD11 molecules, CD11A, B, and C. And you can see that associated with the intracellular part of those integrins are kindlin 3. And kindlin 3 is a molecule that's required for allowing that integrin to exert high affinity interactions. So when the integrins are expressed and kindlin is engaged, then you get the tight adhesion of the neutrophil to the endothelium, and now it can squeeze out between the cells and go off to get its eggs and bacon. So the summary of neutrophil leukocyte adhesion deficiency is really here. There are 3 kinds. They are named not for how they work functionally, but when they were discovered. So LAD1 is here, the mutation in CD18 that leads to a defect in the display of integrins. LAD2 is a defect in the enzyme that fucosylates CD15S, and therefore gives you a bare CD15S on the cell surface. And LAD3 is due to mutations in FRMT3, which encodes kindlin 3 and fails to allow neutrophils to have tight adhesion. So what is the clinical phenotype of LAD1? They have delayed umbilical cord separation, at least in many of the patients. Recurrent bacterial infections, recurrent wound healing, recurrent oral ulcers is a common complaint. And then tooth loss is almost universal by 20 years of age. They have recurrent skin lesions, and they almost always have leukocytosis with neutrophilia. At the histopathologic level, what you see here is, this is a colon biopsy from a young man with colitis. And what you see are lots of neutrophils inside the blood vessel here, but you don't see any neutrophils off in the tissue. There are no neutrophils in the colonic glands, and there are no neutrophils in the interstitium. This is because there are plenty of neutrophils. They just can't get out of the blood vessel. You can see here this very impaired wound healing. On the left is a scab that had been on this boy's calf for several months, and we had to get a surgeon to take it off. On the right is what his elbow looked like after he had had some wound healing, sometimes referred to as cigarette paper scarring. And then you see this really severe gingival inflammation. And in LAD1, almost all individuals lose their teeth by late adolescence. This happens to be an 18-year-old woman, and her teeth were so unstable and uncomfortable that right after this picture, we removed them all, and she was much more comfortable and felt better. Recently, there has been a comprehensive global summary of leukocyte adhesion deficiency, and I've listed the citation here. It's important to keep in mind that although in the older literature, people said that patients with LAD1 died almost universally by age 2 without transplant, this is clearly not the case. But it is the case that there is a genotype-phenotype correlation. So the less of CD18 you express on the cell surface, the less likely you are to survive a long time. And you can see here, I've boxed these two areas: severe CD18, which has less than 2%, severe LAD1, which has less than 2% of CD18 expression, has about 40 to 50% of patients are alive by age 2. In contrast, if you've got more than 2% CD18 on the cell surface, the number that are alive at age 2 and into a young adulthood is much, much higher. So there's an important genotype-phenotype correlation, and that is reflected here in the survival curves. You see in blue, those that have low expression have low survival, whereas those who have higher expression have higher survival. Not perfect survival, but it is much better. Finally, the summary, the worldwide summary of transplant outcomes is important to keep in mind. The overall transplant success is about 80%. However, it's very dependent on how good is the match, and the quality of the match for the donor and the recipient is critically important. And you can see here that when you go to haplo-related transplants, the transplant-related mortality is over 30%, whereas if you're using matched sibling donors, it is 11%. LAD2 is this disease caused by a defect in the fucosylating enzyme. These patients often have the Bombay blood type, some degree of mental retardation and growth retardation. This is due to a mutation in a gene called SLC35C1. It's a complicated name. It also goes by the name congenital defect of glycosylation 2C. Do not confuse CDG2C with CGD. Very confusing, but it is a problem. There is an interesting discussion about whether fucose supplementation can help in this disease. And it looks like it's effective in some mutations and not others. This is what a child with LAD2 looks like, and you can see some mid-face hypoplasia and some hypertelorism. There is a recent paper suggesting that the fucose supplementation can work with some more pictures that help you to get an image of what this condition looks like. And what they find is that fucose supplementation is effective mostly in children who carry the F168del mutation. One example of that is shown here. This is a child before and after, above and after fucose supplementation, and they're looking at the expression of neutrophil CD15S, and you can see that with the red arrow shows you that it has improved after fucose supplementation, and also the ability to display CD15S after activation, as you see on the right, is significantly improved, at least in that one child. LAD3 is really a different disease, and this is the one caused by kindlin deficiency due to mutations in FERMT3. So they're typically born with bleeding into the skin and petechiae because of impaired platelet activation. We talk about this as a neutrophil defect, but it really has profound platelet effects. They get recurrent infections, delayed umbilical separation, poor wound healing, and hepatosplenomegaly. Now, this is just a diagram to remind you that what kindlin does is to allow CD18 and CD11 to form high affinity complexes. In the absence of kindlin-3, as you see here on the bottom, in the absence of kindlin-3, CD18 and CD11 can still be displayed on the cell surface. They just can't achieve the high affinity state that allows them to really adhere properly. Now, what are some of the interesting things that are going on in LAD? I want to highlight the critically important work of Dr. Nikki Moutsopoulos here at the National Institute of Dental and Craniofacial Research. And what Nikki realized is that what drives inflammation in LAD1 is really quite remarkable and not at all what I had thought. So neutrophils are in blood vessels, and when they go out into the tissue, they get ingested by macrophages. Well, it turns out macrophages really like to eat neutrophils. And when a macrophage does not have a neutrophil to eat, as you see in this drawing, it produces IL-23 that tells CD4 cells to produce IL-17, and the IL-17 leads to the production of GCSF, as well as bone loss and inflammation. So when a neutrophil gets out of the blood vessel and the macrophage eats it, it stops producing IL-23, which turns off inflammation and turns off GCSF. So there's a homeostasis in which macrophages are signaling the bone marrow to say, I want more neutrophils. Why is that important in LAD? Because in LAD1, neutrophils can't get out of the blood vessel, so they can't get into the macrophage. So the macrophage is always yelling for breakfast, and the neutrophils can't come give it to him. And that leads to the increased production of IL-23, an increased production of IL-17, and an increase in GCSF and inflammation. That we can prove that this is true because when Nikki went and took biopsies from the gums of patients with LAD1, she could see very high production of IL-17A, as you see here in the center. And that's important because in LAD1, periodontal disease and bone resorption are very common. You can see this young man here. The blue line here is where his bone should have been. The white line is where his alveolar bone was. So he had profound bone resorption that made his teeth very uncomfortable and very loose. And when we took biopsies, we could see that there was very high expression of IL-17 in these very inflamed tissues. So we reasoned that if IL-23 was the problem, and it's because macrophages are not getting neutrophils, we can't simply put neutrophils in the tissue, but we can block IL-23. And ustekinumab is a monoclonal antibody that will block IL-23, which would then turn down IL-17 and reduce GCSF and bone loss and inflammation. And that is exactly what we found. When we gave him ustekinumab, you can see that his gums looked much better. Compare the far left to the far right. In addition, the number of sites in his gums that bled when we tested them went down very substantially. This patient also had a very large wound on his bottom that was extremely uncomfortable, as you can imagine. And with the use of ustekinumab, that wound slowly but steadily healed after having been present for 2 years. So this paper that we published several years ago has been used now as the foundation to create a protocol to treat patients with LAD1 with ustekinumab. The protocol is given here. It's similar to the protocol that is used in inflammatory bowel disease, except the dose is much lower. And maybe the dose that we've used is too low, but we can increase it. And here is the outcomes for the 7 patients that we've treated, including the patient in that New England Journal report. These are all adults, and so you might imagine that they all have more moderate degrees of LAD1, and they do. They've got some residual expression of CD18. And their clinical responses, of the 7 treated, 5 had very positive responses, typically reduction in skin inflammation and oral inflammation and tooth inflammation. 2 patients had no improvement, both of whom had relatively significant mutations. There were no severe infections due to ustekinumab, which was our biggest concern at the beginning. And so far, it looks like these responses are probably better in those who have better CD18 expression. So in summary, it's almost time for you to get breakfast. Leukocyte adhesion deficiencies are recessive diseases that affect neutrophil migration. They also lead to inflammation in unexpected ways because of how macrophages sit in the tissue and respond to the absence of neutrophils. Blockade of the IL-23, IL-17 pathway reduced gingivitis and wound inflammation in LAD1. Transplantation is effective in LAD1 at about 80% success rate. It's also effective in LAD3 and probably in LAD2. And fucose supplementation may improve some cases of LAD2. I'd like to conclude by thanking my collaborators without whom this work would never have been done. Nikki Matsopoulos in particular in the Dental Institute, Betty Marciano, who's the principal investigator on the LAD protocol, and our collaborators in Brescia and the University of Pennsylvania and the Clinical Center here at the NIH. Thank you very much, and I look forward to being with you in person next time.
So thank you so much. I think that since Professor Steve Holland did not join us, didn't make it to join us, so we have no more questions at this step, and we will move to the break. But before that, I would like to announce that there will be a quiz questions which will be available on the website Sunday, starting Sunday, and you need to reply to those questions to get your certificate. So this is a very important thing. So please, for the students, keep aware about that. And we will be back in exactly 12 minutes on time for the
Hello, dear audience. Um, please, it may be a little lag between the live in real time and what you have in YouTube. To be the more synchronized, uh, please close your YouTube and reopen it again to be the more synchronized with our live. Thank you very much.
Hello. So good to have you back. So we will start this second session of this ASID School. The first session was very exciting with excellent content, and I think that the second session will be as good as the first. And our first speaker will be Dr. Kimberly Gilmore from UK. She is consultant clinical scientist and the clinical lead for the immunology laboratory at the Great Ormond Street Hospital in London. So thank you so much, Kimberly, for being with us. And the floor is yours. The talk is diagnosis workup for phagocytic defects. Thank you.
Thank you very much for inviting me. I've been very impressed with the quality of the speakers and more importantly, or equally importantly, the quality of the discussion. So that's been very fabulous. So thank you for having me. As mentioned, I'm going to talk about how we diagnose neutrophil disorders. Okay, so before you think about any diagnostic tests, there are just some reminders I want everyone to think about. And this applies to immunodeficiencies, but it also applies to almost any test you're going to do. So you need to think about atypical presentations. You need to think about technical issues and how different software, different equipment gives you different data or can show data differently. You need to think about other factors that might affect the assay, such as the age of the sample. Was it taken in the right blood container? Did it travel? Did it freeze on an airplane? Did it get very hot in the sunshine? Conflicting assays, what do we do when we have one assay that suggests you have CGD, for example, and one that suggests you don't? And we need to think about multiple diseases in the same family. So we've now had a number of families where by pure bad chance, they carry more than one genetic disease. Okay, so if you're investigating neutrophils, there's some things we need to think about. Are they present? You can do a full blood count and very rapidly confirm if the neutrophils are present or absent, or at least in normal numbers. And you can do that over a period of time for things like cyclical neutropenia. If they're present, do they work? And we think about whether they work in two ways. Do they migrate appropriately? So do they get to the sites of infection? And if they do migrate, can they actually undergo an enzymatic and an oxidative burst or not? If you're setting up tests, there's some things you need to think about. Are these diagnostic tests? Are they monitoring tests? Are they screening tests? What's your patient base? What's the probability that they will be positive? Who are we screening? What you set up in a pediatric hospital may be different than what you set up in a general hospital, might be different than a tertiary hospital, might be different than if you work in a geriatric hospital. Because CGD, for example, is going to be very rare in patients over the age of 80, at least as a novel diagnosis. As I said, are they screening tests or diagnostic tests? So if we think about this, things like a DHR or an NBT screen for CGD, the actual protein expression or genetics is diagnostic. They tell you what kind of CGD you have. How many of these do you do? Like many things in medicine, the more you do, the better you get at it. But how do you quality control? So there's no external quality assessment scheme for many of these. So how are you going to maintain that quality? Are you going to audit against genetic results? Are you going to swap samples with another lab? And what is the cost? How many of these tests do you need to do to make it worth the staff and reagent costs? If you're only going to do 1 or 2 a year, although the test may be very expensive, it still may be cheaper to send it somewhere else than to buy in a very expensive kit, train your staff, do it twice a year. What is your in-house expertise? So with flow cytometers, are we talking 12 color, 8 color, 6 color, or 4 color machines? Do you have staff well trained in flow cytometry? Maybe your staff's very well trained in reading slides, so an NBT might be a better option. And then what is your follow-up test? If you get an abnormal result, what are you doing next? Are you doing a protein test? Are you doing genetics? Are they available local, regionally, nationally, internationally? It's really frustrating to have someone call up and say, well, it's abnormal. What do I do next? If you're doing a screening test, you need to know what the confirmatory test is going to be, or to know that you can't offer it and you're going to just go with that and assume that's the test is right. Okay, this has been mentioned a number of times already, but just to remind you that neutrophils go from the bone marrow into the blood, then to the sites of inflammation. And in abnormal neutrophil tracking and function, there's a number of diseases. So congenital neutropenia, you don't make the neutrophils to begin with. You can also put cyclical neutropenia there, where over time, you have neutrophils and they go away and you have neutrophils. And if you do a full blood count every 2 or 3 days, you will discover that. Then we have diseases like leukocyte adhesion deficiencies, where the neutrophils get from the bone marrow into the bloodstream. They migrate appropriately within the bloodstream, but they can't exit the bloodstream. They're missing the integrins and selectins to allow them to exit the bloodstream, and therefore they can't go to the site of infection. And then we have things like chronic granulomatous disease, where the neutrophils are made, they migrate, but once they ingest antigen, bacteria, for example, they can't kill it. So if we think about neutrophil migration, I know this is a refresher for all of you, the blood is merrily rolling through the bloodstream, and then it slows down. This process is called rolling, and it's dependent on selectins. And once it slows, it can then tether, and that's dependent on integrins. And once it's tethered, it can then migrate across a chemokine gradient and then kill whatever the infected organism is. The integrins, particularly for LAD, we're focused on CD18, and CD18 forms a dimer with a CD11A, so it's an alpha-beta integrin. So CD18 is a beta-2 integrin, and it binds either with alpha-1, alpha-2, or alpha-3. And in patients with LAD, they have neutrophils. The neutrophils can slow down in the rolling process, but they can't tether because there's no integrins. Because they can't tether, they never leave the bloodstream and they keep flowing around. I know Steve's talked about this, so diagnosis of LAD, obviously there's the clinical presentations, and this is a child with LAD with a non-pussy abscess. Really big key that these abscesses or these skin lesions don't have any pus because the neutrophils can't get there. They often have neutrophilia, so a high white blood cell count. You can look at expression of CD18, and low percentage of expression is classic for severe forms of LAD. Depending who you talk to, that might be less than 5%, it might be less than 2%. Moderate is sort of up to 10%. Patients with moderate expression will have mutations. They express some protein. They will get sick, but not as sick as the severe children. Often the moderate children can be managed with antibiotics and things. So this is an example. This is the first child of Maltese parents. Malta is an island, limited gene pool. So there's certain diseases that are quite common there. I will tell you right now, this is LAD1, and it is quite common in Malta. She had delayed separation of her umbilical cord. So again, it's a classic symptom. Her basic full blood count was suggestive because she had a high white cell count with a high neutrophil count. And then we did by flow cytometry, we just looked for surface staining and looked for CD11A and CD18. So this is simply taking neutrophils using fluorescently conjugated antibodies, incubating 10 minutes, lysing the red blood cells, and then doing a forward side scatter gate around the neutrophils. And here in the control, you can see there's good CD11B expression and good CD18 expression. And you can see this patient has virtually no CD11B. There's very little here and virtually no CD18, again, just a trace here. And this is a child diagnosed with LAD type 1, who in fact had a bone marrow transplant and is now well. I'm not going through a lot of the diagnosis for LAD2. LAD2 is defects in selection, so the neutrophils don't slow down, so then they don't tether and then they don't migrate. It's a more severe disease. They have developmental delay, they may be dysmorphic, they have some seizures and growth retardation, relatively few families described. And the best way to diagnose it is actually looking for their blood group. It's very suggestive. It's not diagnostic, it's a screening test. So the actual defect is in GDP fucosynthetase. So they have a fucosylation defect, and it means that they don't express CD15, so the selectin isn't fucosylated appropriately, but it also means they don't fucosylate other antigens, including blood group antigens. So they're considered to have Bombay, or not considered, they do have Bombay blood group, they lack H antigen. And actually screening that way is a really suggestive of LAD type 2. Some have had transplants, some have had fucose. I don't know that we have a good treatment for this condition. Very briefly, LAD3, the integrin expression is normal, but the adhesion is abnormal because they don't signal appropriately. These patients to date have abnormal erythrocyte morphology, so doing a blood film is really helpful. Going on to neutrophil killing, so if you have neutrophils and they get to the right place, do they kill? That requires an opsonized particle to be phagocytosed, and then you can have either enzymatic killing or the respiratory burst, as David spoke about. I'm not going to go through David's CGD talk because he did an excellent job. So we're talking about CGD now. So CGD is based on the NADPH complex. And what happens is that these components, so 22 and GP91 that are on the receptor, the other FOX proteins co-localize, and NADPH goes to NADP. It's activated by phagocytosis and a calcium flux. You're also therefore left with this free hydrogen, which combines with water to form H2O2. As David said, the classic way of diagnosing this, particularly if you're comfortable reading slides, is a neutrophil nitroblue tetrazolium assay. What we do in this assay is we take blood, we feed it NBT alone or NBT plus PMA as a stimulus, and the cells with NBT alone, you can see here a nice neutrophil that's not doing anything, but if we, in the presence of PMA, they burst. And these cells down a microscope look just like this. They look like a sunburst. They go very dark, so the color is actually darker here than here. It doesn't show up. It shows up a bit here, but is significantly darker here than here, and they have burst. It is the only way to describe it, is this burst phenomenon. And I put this one in because it's a really nice picture of a carrier. So here you have a normal neutrophil, and here you can see a burst neutrophil. And carriers of XCGD, as you probably are aware, 50% of their cells approximately will have normal expression, and approximately 50% will have abnormal expression. Okay, if you don't do NBTs, the other common assay is a DHR. And a DHR assay, it's the same general principle. Then we stimulate cells with PMA, but also with F-metlufi and E. coli. You put dihydrorhodamine in, which is non-fluorescent, and then it fluoresces in the presence of hydrogen peroxide and glows green. And you can then see it on a flow cytometry plot by running it through a flow cytometer and then analyzing it. So this is actually data from our lab done about a year ago. I can actually see the data at the bottom. So what we do is we take neutrophils, we add PBS or F-metlufi or E. coli or PMA, and we incubate them with a fluorescent compound, and then we run them through a flow cytometer after we lyse the red blood cells. We always put in a viability dye as well. So we have neutrophils gated here, we have viable cells gated here, and here you can see the PBS, which has a minimum, which has no response, that's our negative. The F-metlufi, which always has a very partial response, nice response to E. coli, and a nice response to PMA. And a couple of things are really important. One, the PMA always should be the brightest of all the stimulants, and it should always come way out. So this is coming out well beyond 10 to the 5 on our flow cytometer. Okay, here's a CGD patient. I think it's very easy to see we've gated neutrophils, we've gated live cells, and here you can see there's absolutely minimum shifts. So if you remember on the previous slide, we were coming all the way out here beyond 10 to the 5, and on this patient, we're all the way down here at 10 to the 3. This is clearly very abnormal. And the percentages are abnormal, but equally important, the MFIs, that fluorescence intensity is very abnormal. Okay, and then this is what I'd call an atypical CGD. So this patient still has a decent response to E. coli, not perfect, because E. coli usually comes out sort of peaking over 10 to the 4, but it has a reasonable response to E. coli, a detectable response to PMA and to F-metlufi, but clearly not normal and clearly not bright out here at a 10 to the 5. But what's particularly important is if you were just using E. coli as a stimulant, you come up with a percentage that doesn't look that bad, 63.4, but actually the MFIs are quite low, and there's no response to PMA. In fact, this is a, I'm not going to tell you what it is because I think I have the protein results next to show you. We'll come back to that one in a minute. Why do you do DHRs and NBTs? What's the difference? What response? What's the same? Okay, so the patients with CGD are pretty much the same with all of them. You might get a bit of burst with the DHR. The normals are pretty much the same for all of them. It's important to know that DHRs also are abnormal in patients with specific granule deficiency. Where the NBT was normal, the DHR here is abnormal. Our carriers, you pick up very similarly. And some of these atypical CGDs that have abnormal NBTs often have a percentage that looks okay by DHR, but in fact, they fail to have good MFIs. So what you do depends on your lab, depends on your, do you have lots of microscopes? Are people good at reading slides? Do you have flow cytometers and people are really happy using them? Which assays can you get? Our NBT is pretty much a home brew. We buy PMA from Sigma, we buy NBT from nitroblue tetrazolium from Sigma. We make them up in our lab. It takes a blood film. It's really cheap and easy to do. The DHRs you get a little more information on. They are much more expensive to run. This is just to remind you that you need to check your controls and decide when you're not reporting things. So for example, this one has a failed E. coli and this one has a failed PMA. And if the control fails that you run at the same time, we don't feel you necessarily can report the patient. If the patient's normal, you worry that the samples have been swapped. If both are abnormal, you worry that something happened with the assay, transport, the water bath wasn't the right temperature, any of those things. Okay. How do you interpret DHRs? And this is just another slide to remind you of how important it is not only to look at percentages, but MFIs. So these were both patients, we didn't get a lot of neutrophils, so I'm sorry for that. But here you can see the E. coli and the PMA, and these are 100% with high MFIs. And here you can see the patient whose percentages, PMA is 96%. If you just saw that as a percentage, you'd go, oh, it's okay. But you can visually see that the MFI is much, much lower. And this is in fact a patient whose NBT was 88%, but by looking down the microscope, you could see they were pale blue, they hadn't burst properly. And he in fact has a hypomorphic mutation and had XCGD. And it's just to remind you how important it is to look not only at percentages, but MFIs, and to look down the microscope at the slides, because these were clearly very pale, they just didn't look right. A reason why you have to gate properly. So this is gated on neutrophils and viable cells, and you can see what it looks like when gated properly. That's a tight gate. This is the exact same sample, but a big gate, a loose gate. You can see how bad this looks. This starts looking slightly abnormal. It's not abnormal at all. It's just technically not done well because we have a big gate here. We have a bunch of dead cells here. So if you gate tightly and properly, you get much cleaner results. Dead cells don't undergo a neutrophil burst. Okay. Just to remind you, I think David went through this, the molecular basis of CGD. So we have the 4 main genes, a few P40 autosomal recessive families, and just to remind you that EROS is a transcription factor that helps regulate GP91, and there are very few of those families described so far. We, to my knowledge, haven't seen one at GOSH yet. This is how you can detect which kind of CGD it is. So you can look at protein expression by flow cytometry. This is a carrier who happened to be mum. And you can clearly see she has some cells that have normal GP91 expression and some cells that are abnormal. You can see the patient lacks GP91 expression altogether. And if we do it by blot, mum has some GP91, patient doesn't. This is a smear because it's a glycosylated protein. So you get different glycosylation sites, which is why it smears out. Here, going back to our favorite patient or his control, again, we get neutrophils, and this is intracellular facts for the different FOX components of 47, 67, 22, and P40. So we have an isotype control, and then you can see expression of all the proteins. And again, it's important to look at percent, but also MFIs. And then if we go down, you can see, so here, if we focus on the P40, which is right here, this middle orange one, and the MFIs 4,000 plus. And then you can see how it's very much shifted to the left, and the MFI is only 689. And this patient, in fact, had that atypical DHR that I showed a few moments ago, and has P40 CGD. Okay, this is a very busy slide, and I apologize for it in advance, but we're here talking about 2 different assays that I think are important to mention in neutrophils. We've relatively few patients who've been diagnosed with defects in these pathways. So one is a phagocytosis assay. In the phagocytosis assay, you feed neutrophils FITC-labeled E. coli. The neutrophils eat the FITC-labeled E. coli, and therefore the cell fluoresces. What's really important is you have some FITC-labeled E. coli stuck to the cell surface, and those will fluoresce as well. So you have to use trypan blue or another dye to quench them. So you only detect the E. coli that's been actually ingested. That's a really important part of the assay. So you gate neutrophils, and then you can look at them as a histogram like we did before, and you can feed them. So we tend to do a 0, 2, 5, and 10-minute time course. And here in black is a normal 5-minute and 10 minutes. So lots of eating. And here in red, you can see we have very delayed eating at 5 and at 10 minutes. This happens to be a patient with an MKKL1 has MKKL1 deficiency. It was the first one described. It's a fairly rare defect. The other patients that have had abnormal phagocytosis have had mutations in CEBP epsilon, which is a transcription factor. I've been doing this for quite a while now, and we've had 3 CEBP epsilon patients and 1 MKL1. So phagocytic mutations are or defects in this pathway are relatively rare. It is a very easy assay to do, though. The other thing I thought I'd briefly mention is L-selectin shedding, because these are defects in TLR pathways, and you can look on neutrophils for expression for these. These patients aren't necessarily pure neutrophil defects because these pathways are also on lymphocytes as well. But again, these are very easy assays in the sense that you stimulate cells, you leave them for a while, you surface stain them for 62L, or we also surface stain for CD11B, and you see if they've shed or not. And here is a control, and we have PBS, which is unshed, and then we have LPS and PMA and a whole bunch of other stimuli, and you can see that everything is shed. PMA is your PMA should shed normally, and this is a patient who in fact has IRAK4, and the pink is PMA that has shed over there. You can't actually see it, and here you can see his pink is shed, but the rest hasn't, or not all the other patient pathways have, but in particular, the tube 2, the LPS here, the green is way over here. Here we haven't shed it at all, and this patient had a confirmed IRAK4 deficiency. So I don't necessarily think of IRAK4 as a pure neutrophil defect, because it is, as I said, expressed on other cells, but this is an easy assay you can do to help screen for that. Okay, you've done your screening assays, you've done your DHR, it's abnormal, you may or may not have done protein analysis. If you've done protein analysis, you can then do very targeted sequencing. So if you know the P47 is abnormal, just sequence the P47 gene. If you know you're really suspicious that IRAK4 is abnormal because of your L-selectin shedding assay, just sequence IRAK4. It is still cheaper and easier to do single gene analysis than to do next generation sequencing. And you can do next generation sequencing either by a panel where you look only at a certain number of genes, by whole exome sequencing, or whole genome sequencing. So whole exome, you're looking at all the coding regions of the genes. Whole genome sequencing, you're sequencing everything. The reality is that most people are only analyzing the exome coding regions and maybe a bit of the splice regions. It's really important at this point with NGS to say that there's a pseudogene for NCF1, so P47, that sits really close to it and is 90% identical. So when you do next generation sequencing, because you're looking at little snippets of sequence that you paste together, it's really hard to distinguish the pseudogene from the P47. So if you think they're P47 deficient and you do whole exome or whole genome sequencing and don't see anything, you may have missed it because you're putting the computer algorithms are putting together the sequence from the pseudogene, which might be normal. So you're not seeing your abnormal. So if you think that's what it is, it's really worth doing Sanger sequencing to try and find it. Okay, so a few minutes on genetic sequencing. So historically, obviously, we sequenced single genes. Then as next generation sequencing became more utilized, a lot of people sequenced panels of genes. And this is just an initial example of a panel we were doing at Great Ormond Street that initially was 100 panels. Then we moved to doing 300 genes on a clinical exome. Now we've moved to doing whole genome sequencing, but with a virtual panel. And what I mean by that is that the whole genome is sequenced. but we only analyze the genes on the virtual panel. And that panel is basically based on the IUIS classification of immunodeficiency. And the reason we do that is by doing a virtual panel, you don't have to worry about incidental findings. So you only look for immunodeficiency genes. It's relatively rapid because we're only screening known genes. It does require a lot of bioinformatics still, and you still have the issue of what you do if you get a sequence variant. So a sequence variant is neither a polymorphism nor a pathological finding. It's exactly what it says on the tin. It's a sequence variant of unknown significance. Might be pathological, might not. And those all need functional validation because you don't know if it's pathological or not. There's been a lot of data that's been done to try and identify novel genes. In the UK, we're very fortunate in that we now have whole genome sequencing provision from April 2022. It's really important to highlight you can still miss the diagnosis. So you can do all this sequencing and still not find the problem. And that's for a number of reasons. It might be in a novel gene because we're not doing gene discovery. It might be in a non-coding region. So if it's in the promoter, if it's an enhancer, if it's a regulatory region that we don't even know about, those aren't being reported. The whole genome sequencing is not great at copy number variation. So if there are duplications and deletions, sometimes it picks it up, but sometimes it doesn't, particularly if it's a run of the same letter. So if it's an AAAAA, and you've taken one of those out, it may or may not detect it because of the slippage in the way you paste these together. They're better detecting like a whole exon is gone, or if it's a slightly bigger or different. So if you take out an A, T, and a C, it's less likely to be able to paste it together properly, but particularly when you have runs of the same nucleotide, it's not very good at picking those up. And as I mentioned, if you have pseudogenes, it can't tell what's a pseudogene and what's the real gene if the homology is the same. So it'll paste the pseudogene in where the real gene is. So I think genetics are coming down in price. I think they're hugely helpful. They are slow, and you can get incidental findings if you don't restrict your what you're looking at, and it won't get everything. I think that's a really important message. Genetics doesn't detect everything. And you may get these variants of unknown significance that need functional validation. So if you suspect a primary immunodeficiency order, this is any PID, but it's very appropriate for phagocytic disorders. Obviously, you take a clinical history and then you do a physical exam. If you can biopsy something, that's very helpful because if you know it's fungus, you always sort of worry a lot more about things like CGD, mycobacterium. The bug you find may help guide what you think it is. A full blood count with a differential is hugely helpful, particularly if it's neutrophilia. You immediately start thinking about LADs. If there are no neutrophils, you think about congenital neutropenia, things like that. Do the easier tests first. So if you have a good history, they have neutrophilia, they had delayed cord blood separation, you're thinking about LAD, you can do CD18, CD11B quite easily. Functional assays, NBT, DHRs, and depending on what those results show, you can either do protein-specific expression like P40, P47, GP91, or go straight to genetics. So in conclusion, please remember the obvious, that's the most likely thing to happen, but do be aware of atypical presentations. The P40 CGDs, for example, a lot of we have one family where we have a father and 6 children who all have P40 deficiency, and they've only presented really with abscesses. They haven't had any of the other classic CGD. And of course, dad's in his 40s and has had all these children. Half the children have CGD. I will point out the other half don't. It's a very large family. Ensure technical precision. I hope I demonstrated that by the importance of tight gating. Remember that neither protein or genetics is perfect. You can express protein that's non-functional, so it looks normal, but it's not. Genetics won't pick up things that we don't know about, things in non-coding spaces, copy number variations, and things like that. Always think about alternatives. We've seen 2 diseases in the same patients, and we've certainly seen 2 diseases in the same family. So we have a family with RAG, SCID, and beta thalassemia. So both cured by transplant, fortunately, but 2 diseases in the same patient. We've had a family who've just published with FLH3, so hemophagocytic lymphohistiocytosis in one child and XLP in the other child. So we've seen that as well. Please seek help. I'm happy always to answer emails and things. There's lots of contacts in ESID in your wider network, and ASID is really helpful. You know, ask for help, seek advice. We're all here to try and help. Lastly, I'd like to just acknowledge my colleagues in the immunology lab. So Matt Buckland covers for me when I'm away. We have a really strong collaboration with the Northeast Thames Regional Genetics Lab. And most importantly, we want to thank the patients and all my staff over the years for all the support. Thank you very much, and I'm happy to take questions.
Okay, thank you so much, Dr. Gilmore, for this excellent talk. So we do not have questions in the chat, but I will have one or two questions to you, please. So first of all, in terms of screening strategy, you are still starting with the NBT assay, as far as I understood.
Yeah, so
the outcomes are the second step.
So we do our general screening test is NBT because we've never missed a classical CGD with an NBT. So if you're considering CGD, we always do an NBT. The exception would be the P40 patients, but all our P40 patients that we've had have had a lot of cutaneous or skin abscesses. And if that's what we think it is, we'll just go and do a DHR and not do an NBT because we know the NBTs on those aren't as sensitive. But for all our classics, so patients coming with fungal infections, IBD, those types of patients would just go and do an NBT, mostly because it's very fast and it's very cheap. I mean, NBT costs us like 20 pounds to do, and a DHR is over 100. And we also have limited resources. So that's why we do it.
But maybe we know as well that it is a semi-quantitative assay, and maybe sometimes DHR is much more appropriate to quantify the defects for the residual, particularly for the residual defects. So when do you do DHR after the NBT?
Okay, so if the NBT is completely abnormal, we'll probably go straight on and do proteins. If the NBT gives us what I call those pale blue cells, so they're trying really hard but not quite bursting, or we get an intermediate response, so we actually count those cells and we have 12% normal, 20% normal, 50% normal, then we'll always do a DHR because it's quite helpful. And the reality is, if you're only doing one and resources aren't an issue, I would choose the DHR because you do get more information from it, particularly if you do the E. coli and the F-metlu-Phe. But if resources are tight, then the NBT is a much cheaper assay.
That's right. So, and there's no risk with the myeloperoxidase deficiency to miss it when you have a DHR which is slow?
Yeah, so if you're, I don't know if I understood the question completely, but if your DHR is low, it may be CGD, but it could be myeloperoxidase. It could be specific granular deficiency. So you can't distinguish on a DHR which is which.
Yeah. So I mean, that's why maybe NBT is still useful for this. This is an additional reason, but because it will be normal.
Yeah. Exactly.
So it's very specific for CGD, I mean.
Yeah, exactly. You're exactly right. The NBT is exquisitely specific for CGD. So if it's abnormal, it is CGD.
If you don't mind, my second question is about once again, the screening. So in a country where we have mainly autosomal recessive form of diseases, like in our region, for example, how would it be, and we have limited access to genetic testing, would it be interesting to have monoclonal antibodies, Western blot, using monoclonal antibodies against the different subunits? Would it be useful from routine point of view? I mean?
Yeah, I think you could do either the immunoblot very easily, or even easier, probably if you have the flow cytometers, is to do it by flow cytometry. So the intercellular staining is really easy. And I'm happy to share that protocol if people want to email me, because I think that, so up until we really were doing a lot of gene therapy, we never did genetics. We did the DHR and NBT, we did the protein. If the protein was absent, you know, you had XCGD, you had P47, you had P67, you were put in whatever box you were put in. And then we went ahead and treated the patients. And the main reason we do genetics now is that we need to do genetics for gene therapy, because it's a legal requirement that you have the gene mutation before you do gene therapy.
Okay, thank you so much. So I think that maybe the other colleagues have some question, Nasreen or Nahla?
Yes, actually,
Hello?
yes, hi, can you hear me? Yeah, you touched on one of the questions that I was just about to ask. We have this patient, he's a young man with an extraordinary history of brain abscess with Pseudomonas. And he was treated for that. And then because his brother was a doctor, he was sent to us in the clinic. Digging in the history, we found that he actually did have issues with minor boils, recurrent boils and carbuncles and that. But otherwise, he's been perfectly well. We did also just a part of his general screens and the adventures that we do in the clinics. We did his CT chest, despite he didn't have any complaints, significant complaints. And to our surprise, we found that he was bronchiectatic. Immunoglobulin levels and basic lymphocyte subsets were normal. And we also had the luxury of doing a DHR at that stage, and that was normal. You know, we just kept him. I mean, we couldn't do anything further. And I was obviously thinking of the myeloperoxidase deficiency. And this is one thing. So I will email you about the, you know, regarding the protocol for myeloperoxidase. But the other thing that I think we need to do is to re-establish the MBT here at home, because tens of years ago, while I was still doing my training, we did have the MBT, but now we don't have it. We don't seem to be able to source it or to get, you know, the kits from somewhere. It was the hematologist who used to do it in the past, but they don't seem to be able to locate, you know, where to get the reagents and that. So I think that's another thing that we need to do, please, because with the DHR, it's very unsustainable within our environment, and I think it's important to have the MBT. We do see many potential CGDs around here.
So I'm very happy if you send me an email, you know, the next day or two, I can send you our protocol. As I said, we're literally buying the reagents from Sigma, and we just use the same slides we use for blood films in the routine hematology lab. Sure.
Okay. I'll get in touch with you in that regard. Yeah, that's fine. And the other question is actually about the phagocytosis assays. Until a few years back, these were very they were not quite standardized in a way. And you were speaking about the E. coli assay, and I just wanted to know how is that doing on NEQUAS, or is there a NEQUAS scheme for it? I mean, so how is it doing? Was it still, you know, it depends on the operator? I mean,
okay, so we now buy a kit, to be perfectly honest. So we buy a kit that's now CE marked, so that provides a certain level of what you're getting. We do local sample swaps, so we sample swap with, you know, other labs in the area, because it's neutrophil, so it's really hard to set up a NEQUAS scheme or swap samples any significant distance. What I can say is that every abnormal we've ever had, We've always found a mutation. So that's point one, which is good. So if it's abnormal, we're highly likely to find a mutation. I worry more about what are we missing. Now we have so many patients going through whole genome sequencing. We haven't yet missed anything, but that doesn't mean we aren't missing things, if that makes sense. So I can't obviously speak about new genes and things, but a lot of our patients now go through who had normal phagocytosis. We don't find a relevant gene in, their whole genome panel. So we don't think we're missing any, but that's how we do for ISO accreditation, we do two things. We do a sample swap and we audit against genetics.
Okay, that's
Thank
helpful.
you.
Thank you very
So,
much. Thank you.
Yeah, we maybe have our last question from Nisreen, or is it okay?
Nisreen, you are.
Nisreen is not connected.
Okay. I just wanted to ask you about a patient whom I've seen in Children's Cancer Hospital. He was, as we considered, he was normal. Then he had this lymphoma. He took his chemotherapy, and then he developed this huge fungal mass in his brain. We did the DHR, and it was normal, but we believe, and other assay as the immunoglobulins and the lymphocyte subsets all were normal. But we believe that there is a defect in the phagocytic function because all his infections were fungal. So if there anything we could help him to get him a diagnosed other assay?
You don't think it's just all secondary to his chemotherapy for his lymphoma and the fact that he may have become very neutropenic during that process? I guess that would be question one. I think if you've done all the things you can do, then to some extent, if you can get genetics done, that may be the next best thing, because I think if you have a normal DHR, normal phagocytosis, normal immunoglobulins, normal lymphocyte subsets, you're gonna be looking for some kind of a regulatory gene. And I think the easiest way to find those is probably with genetics.
Local genetics. Okay, thank you.
Okay. Hello?
Yes. Hi.
So thank you so much, Dr. Gilmour, for this excellent talk and for this discussion, interesting discussion. And let's move to the talk by Professor Nermeen Galal, and Nahla will introduce Dr. Galal.
Are we ready? Yeah. So our next talk is a very interactive and lively talk that is going to be presented by my very dear colleague and friend, Dr. Nermeen Jalal, Professor Nermeen Jalal, who is a professor of pediatrics and who is currently leading the pediatric immunology clinics that affiliate with the University of Cairo. So welcome, Nermeen, and we are very delighted to have you here. Can I just remind you that Nermeen's talk is an interactive talk. So there will be MCQ questions that will be posted on the YouTube chat. We ask all of you to respond to the questions as they come, and then we will have a display of the answers, and the correct answer will be explained by Dr. Jalal. Welcome, Nermeen, and happy to have you today.
Thank you, Nahla. Always delighted to be part of the ASID activities. And now we'll get straight to the cases. There's a slight delay, so we'll have to wait out just till the poll results are out so we can discuss your answers. Okay, so our first case is a female, a 3-year-old female that was born in a non-consanguineous family with family history of male SIB death at 1 year with umbilical sepsis and a female SIB death at 1 month with meningitis. History of present illness started at the age of 1 week where she developed a right axillary ulcer, followed by the development of right otitis media mastoiditis at the age of 3 months. Imaging then revealed that the right external and middle ears were opacified by hypodense material with erosive changes of the mastoid and middle ear ossicles. Cultures then revealed a growth of Staphylococcus aureus. At 5 months, the bony boundaries of the right petrous bone were rarefied with stenosis and cortical erosions with extension into the squamous portion of temporal bone. The new cultures then revealed a growth of Pseudomonas aeruginosa. And at 7 months, imaging showed further obliteration erosion, and the new isolates revealed a growth of Aspergillus fumigatus. All the following antimicrobials were received at different intervals to cover the isolated pathogens, unfortunately with very little improvement or almost no improvement for the patient. Her serial blood pictures revealed a leukocytic count that ranged between 9,700 and 15,000 with neutropenia and relative monocytosis. As you can appreciate in the first 2 columns, the absolute neutrophilic count ranged between 97 and 150, and this was corrected after therapy, as we'll see eventually. The rest of the investigations revealed that virology studies were negative, and the bone marrow aspirate revealed a marked maturation arrest of neutrophilic precursors at the promyelocyte and myelocyte stages, moderate eosinophilia and mild monocytosis, and whole exome sequencing revealed a heterozygous missense variant in the elastase gene. Now we get to our first question. So what is your diagnosis? Option A, cyclic neutropenia, B, severe congenital neutropenia, C, autoimmune neutropenia of infancy, D, drug-induced neutropenia. Please vote. The right option here is severe congenital neutropenia, option B. There's no cyclic pattern in here, and autoimmune neutropenia of infancy is a relatively benign condition, and the condition started prior to the intake of any drugs. Next question, please. Which of the following options is true in severe congenital neutropenia? Option A, mode of inheritance can be autosomal recessive or autosomal dominant. Option B, mutations in GCSF receptors are found in all cases. Option C, mutations in NCF1 are found in most cases. And option D, mutations in elastase are found in below 10% of cases. Please vote. The correct answer here is option A, because mode of inheritance can be autosomal recessive or autosomal dominant. Mutations in the GCSF are not found in all cases. Mutations in NCF1 are obviously found in CGD, and the mutations are found in the majority of cases. Next question, please. A problem that usually persists after therapy is option A, low neutrophil counts. Option B, compensatory monocytosis. Option C, periodontitis. Option D, infection rate. Please vote. The right answer here is option C. The periodontitis usually persists after treatment. The low neutrophil counts, as we've seen in the patient's blood pictures, have risen to enough levels after treatment, and the compensatory monocytosis has resolved together with improvement in infection rates subsequently. Now we get to our second case. Our second case is a 3.5-year-old female that was born in a consanguineous family. And the history of present illness showed recurrent otitis media that started in infancy. She was hospitalized twice with pneumonia at 8 months and at 3 years. She was initially following up with our fellow hematologists and diagnosed as a case of severe congenital neutropenia because her absolute neutrophilic count never rose above 600. She continued to suffer angular stomatitis, dental caries with crown prosthesis introduction, and diarrheal attacks were on and off, but they progressed into severe steatorrhea that caused severe failure to thrive for the patient. Actually, she was born on the 50th centile, and her centiles, weight and height, later switched or were shifted to below the 3rd centiles for her age, and the Z-score was -3. The blood picture, as we just said, had an absolute neutrophil count of around 500 with monocytosis. She had a normal hemoglobin level, kind of, and the leukocytic count was low. The AST and the ALT, the liver enzymes, were elevated 4-folds the normal, and she had an increase in the 72-hour fecal fat. And radiology revealed that she had a delayed bone age and transverse sclerotic changes at the metaphysis of the distal femur, as you can appreciate in the lower imaging. There was also marked fatty infiltration of the pancreas on imaging, as you can see in the upper imaging. So now the first question for this case. What is your provisional diagnosis? Option A, Shwachman-Diamond syndrome. Option B, Barth syndrome. Option C, Cohen syndrome. Option D, glycogen storage disease. Please vote. And the right answer here is option A, Shwachman-Diamond syndrome. As we've heard in the previous talks, Barth syndrome is usually associated with cardiomyopathy, myopathies. Cohen syndrome has microcephaly, mental retardation, other skeletal anomalies. Glycogen storage would be associated with hepatomegaly, lactic acidosis, and hypoglycemia. So the right option here is option A. Next question, please. What is the most common non-hematological abnormality in Shwachman-Diamond syndrome? Option A, pancreatic insufficiency. Option B, elevated transaminases. Option C, rib cage abnormality. And option D, short stature. And the right option here is option A, pancreatic insufficiency, because when you come to decide on the diagnosis of the syndrome, this constitutes the hallmark of diagnosing Shwachman-Diamond, along with the cytopenias and other changes. Elevated transaminases are not quite specific. Rib cage abnormalities are quite common, but not in all cases. Short stature is not specific. Next question, please. Treatment includes all except option A, monitoring hematological abnormality. Option B, pancreatic enzyme replacement. Option C, hematopoietic stem cell transplantation for patients with pancytopenia/MDS. And option D, granulocyte colony stimulating factor for mild neutropenia with low infection rate. Please vote. And the right answer for this question is Option D, because all of the above options are true answers. You do have to monitor the hematological abnormality. You have to have pancreatic enzyme replacement and stem cell transplantation for patients with pancytopenia or MDS. If you have a mild neutropenia with a low infection rate, you do not necessarily need to administer GCSF because of fear it might steer things in the direction of malignant transformation, since those patients are predisposed. Now we get to our third case. Our third case is a 3-month-old female born to consanguineous parents with 2 normal SIBs. History of present illness started when she was vaccinated on day 7 with a BCG, and then she started to develop fever spikes that were first attributed to the vaccination. Later on, she developed skin rash, macular, as demonstrated in the picture above. And this was associated with umbilical stump separation on day 35 with ampulitis. And Doppler studies then revealed portal vein thrombosis. At 6 months, she started to suffer bilateral ear discharge, pneumonia, and buttock ulcers. At this stage, patient's blood picture revealed leukocytosis. Her TLC ranged between 36,000 and 90,000. She had thrombocytopenia and anemia. And initially, she was given a diagnosis of severe sepsis with a leukomoid, a query-leukomoid reaction because of the pancytopenia associated. Flow cytometry results revealed that she had a CD18 expression of 0%. This is not that of the patient, but it's merely for demonstration. At this stage, this was quite enough for diagnosis, but this patient somehow managed to get a molecular test, and the molecular test revealed that she had a defect of the integrin beta-2 gene, and the following mutation was demonstrated in the patient's results. So the first question for this case, please. This patient most likely has which of the following conditions? A, Shirek-Higashi syndrome. B, acute myelogenous leukemia. C, leukocyte adhesion deficiency type 1. And D, chronic granulomatous disease. Please vote. And the right answer here is option C, leukocyte adhesion deficiency, because she has a defect of the integrin 2 beta-2 gene, and the flow cytometry showed a severe condition since her CD18 expression was below 0.5%. Next question, please. A patient with LAD would be expected to have, or leukocyte adhesion deficiency would be expected to have, option A, neutropenia. Option B, a few neutrophils in the abscess and a high leukocytic count. Option C, a hypocellular marrow. And option D, a mutation in the gene for NADPH. Please cast your vote. And the right answer here is option B, because this patient would not have neutropenia. They would have neutrophilia and leukocytosis as demonstrated earlier. They would not have a hypocellular marrow. And mutations in the gene for NADPH are obviously concerned with defects of chronic granulomatous disease. Next question, please. Which of the following statements about leukocyte adhesion deficiency is false? Option A, it is an autosomal dominant trait. Neutrophils are unable to exit the circulation. Option C, often leads to marked leukocytosis. And option D, increased bacterial/fungal infections commonly happen. Remember, we're looking for the false statement. And the right answer here is option A. Actually, the false statement is the option A, because this is not an autosomal dominant trait, it's an autosomal recessive. And the rest of the following options, neutrophils are unable to exit the circulation as demonstrated in the previous talks. And patients do have marked leukocytosis, which is commonly confused with malignancy or leukemoid reactions. And they do have a tendency to develop bacterial/fungal infections. Now we get to our final case. This is a 13-year-old male that was born in a consanguineous family. At 3 years, he developed unresolving pneumonia. At 7 years, he developed mediastinal masses with destruction of cervical vertebrae. Aspiration pathology then revealed a granuloma with epithelioid histiocytes, and the microbiology revealed a growth of atypical mycobacteria. His CT chest revealed that right upper paramediastinal soft tissue mass extending from the right mediastinum with right hilar, paratracheal, and para-aortic lymph nodes. The mass was filling the costovertebral gutter, and there were bilateral patchy and nodular opacities with consolidation in the lungs. He later went on to develop hepatosplenomegaly, jaundice, high fever spikes, and ferritin, was screened for HLH, and he fulfilled the criteria, started to receive treatment and improved. Later on, a few months later, he started to develop a foot mass that destroyed the metatarsal bones, and followed a few weeks later by development of teeth abscesses and severe headache. The headache prompted the use of imaging. The MRI brain revealed an ovoid subcortical parietal lesion, variable size patchy areas in the left side of the midbrain, and both cerebellar lesions with involvement of the right lateral orbital bony wall. The MRI spine revealed a kyphotic gibbous deformity at D2, 3, and 4 with vertebral collapse, as you can appreciate in the findings. And the microbiology results obtained then revealed growth of Aspergillus fumigatus and Staphylococcus aureus. This patient in 2016 was diagnosed with a large left lower lobe cavitary lesion with enhancing wall that measured 4.5 times 7.5 centimeters, and then went on to develop headache again with swelling in the left frontal bone. At this stage, the CT brain revealed a focal left frontal calvarial cortical thickening. He underwent spine surgery in 2019 to correct the kyphotic gibbous deformity, and biopsy obtained during surgery revealed granulomatous aggregates of epithelial cells, neutrophils, rimmed lymphoplasmocytic inflammatory cellular infiltrate. In 2020, he developed convulsions and a left high parietal space occupying lesion causing mild mass effect. This patient had a dihydrorhodamine assay. His sister was also symptomatic. They were both assayed, and the stimulation index was very low for both children. Actually, they had an intracellular protein testing, as Dr. Kimberly was just mentioning at that time. The protein testing by flow cytometry revealed a P47 deficiency. As you can appreciate, this is the imaging of the patient or the results of the patient, as you can see in the lower part. And confirmatory molecular testing revealed a homozygous mutation that confirmed the diagnosis of chronic granulomatous disease. Now we get to the questions about this case. The following statements about CGD are true except. So now we're looking for the wrong statement about CGD. Option A, it results from a defect in NADPH oxidase. Option B is diagnosed by dihydrorhodamine assay. Option C is transmitted in an autosomal dominant pattern, and option D may be associated with autoimmune features. And the correct answer here is option C, because it is not transmitted in an autosomal dominant pattern. Actually, as we've seen in previous talks, it's either autosomal recessive or X-linked. It does result from a defect in the NADPH oxidase, and you can diagnose it by the dihydrorhodamine assay, and it is associated with autoimmune features in a lot of cases. Next question, please. Catalase-producing organisms are typical pathogens that may infect patients with CGD. Which of the following is the most likely to cause death, as we've seen in Dr. Ryan's presentation at the beginning? Option A, Aspergillus species. Option B, Escherichia coli. Option C, Pseudomonas. And option D, Staphylococcus aureus. Please vote. And the right answer here is option A. The Aspergillus, as we've heard in previous talks, has a tendency to eat through bones and tissues and act in a very invasive manner. So this is commonly associated with most mortalities. The next question, please. Now, this is kind of a controversial question, depending on which part of the world you're practicing in, but which of the following can be life-saving when infections in patients with CGD are severe? Option A is granulocyte transfusion. Option B, interferon gamma. Option C, posaconazole. Option D, trimethoprim sulfamethoxazole. Please vote. And the right answer here is option A, granulocyte transfusion. As we've heard in previous talks and Dr. Goldblatt's presentation, interferon gamma is not commonly used in the UK, is commonly used in North America for prophylaxis or as an adjunct therapy to treatment. Posaconazole, trimethoprim sulfamethoxazole are agents that are used for prophylaxis. In our area or our part of the world where you do not have access to hematopoietic stem cell transplantation or to gene therapy, sometimes physicians have resorted to granulocyte transfusion to help with severe infections till you sort the patient's plan out. Thank you all for your attention and participation. On behalf of Cairo University's clinical and lab teams, thank you for your attention.
Okay, so thank you so much, Professor Nermeen Galal, for this excellent session of case presentation and discussion. We will have probably the percentage of positive responses that we've got from the students later. And let's move now to the last talk, which should have been presented by Dr. Reem Al-Fakhi. And I would like again to acknowledge her great efforts organizing this ASID school. She was really the key person who did organize it, and I thank her again for all those efforts. And very kindly, her colleague Nasreen Radwan accepted to replace Reem in very short with very short notice. And Nasreen Radwan is lecturer of pediatrics at Ain Shams University in Cairo, Egypt. And she's going to talk to us about management of phagocytic defects to conclude this school. The floor is yours, Nasreen.
Good afternoon, everybody. This is Dr. Nasreen Radwan. I'm a lecturer of pediatrics in Ain Shams University in the Allergy, Immunology, and Rheumatology unit. Today, I'm going to talk to you about the management of phagocytic defect. The objective of my talk, I'm going to do a quick wrap up about the types of phagocytic function, and then I'll talk about the management of the top 3 diseases, which are the chronic granulomatous disease, severe congenital neutropenia, and leukocytic adhesion defect. As we have taken all through the day today, that the defect in the phagocytes are either in the number or the function of the neutrophils. Patients are susceptible to severe recurrent fungal and bacterial infection. Most common sites of infections are the respiratory tract, lymph nodes, and skin. And patients could develop tissue or organ abscesses. There are other non-infectious manifestations as eczema, dermatitis, abnormal wound healing, and growth failure, granuloma formation or inflammatory bowel disease as in patients with chronic granulomatous disease, heart defects as in patients with Barth syndrome, psychomotor retardation, and microcephaly as in Cohen syndrome. Almost all patients are diagnosed in infancy due to severity of infection or unusual organism presentation. However, there are some group of patients who could escape this period and become diagnosed in adulthood. Based on the IUIS phenotypic classifications, we've seen today that the phagocytic dysfunction could be either in number or function. Those in number could be syndromic as the Shashwan diamond, glycogen storage disease type 1B, and the G6P3 deficiency, Cohen's and Barth, or non-syndromic as the severe congenital neutropenia types, the elastase deficiency, HEX1 deficiency, known as Costman disease, X-linked neutropenia, and neutropenia with combined immune deficiency. For the defects in the neutrophil function, it could be due to syndromic disease or non-syndromic. Non-syndromic are furtherly divided based on the DHR. If we have a normal DHR, it could be a GATA2 deficiency or protein alveolar proteinosis, or abnormal DHR as in CGD. For the syndromics, we have the 3 types of the LAD 1, 2, and 3, Papillon-Lefebvre syndrome, and the cystic fibrosis. Then we're going now to talk about the chronic granulomatous disease. I'm not going to talk about what the main defect, as it had been said previously in all lectures, but I'm going to wrap up some important points that these patients, most of them present early in life. They have recurrent bacterial fungal infection. Atypical mycobacterium could be there. Some patients present with HLH, and most of the causes that trigger this HLH are infection. Patients with CGD and X-linked carrier could present with systemic autoimmune manifestations as lupus, juvenile idiopathic arthritis, antiphospholipid antibody syndrome, immune thrombocytopenic purpura, and IgA nephropathy. The pathogenesis, as we said, known today, is due to defect in the NADPH oxidase. There is a defect in the oxidative respiratory burst of the neutrophils, so they cannot do intracellular killing for the bacteria and the fungi. There have been several types of the CGD. The X-linked type, it's due to the mutation of the GP91, and the autosomal recessive, it's due to mutation of the P47, P67, P40, which regulates the GP91, or the membrane-bound P22 that stabilizes the GP91. In some studies, it has been reported that the X-linked type is more aggressive than the autosomal recessive. The clinical picture is infections, as we have said, and inflammatory condition as inflammatory bowel disease, non-infectious arthritis, gingivitis, chorioretinitis, uveitis, granuloma formation, and to differentiate this granuloma in the colitis from those who had an autoimmune inflammatory bowel as Crohn's, there would be a histocyte aggregates with a surrounding lymphocyte infiltration, and they have less staining of the macrophage marker, which is the CD68. And there have been this nice study that mentioned the long-term outcome for adults with CGD in the UK, and they have highlighted that the most serious morbidity coming from the non-infectious complication and the granulomatous inflammation in the GI or in the lung. And presence of the disease in adulthood did not predict that it is less severe than presenting later in the childhood. And the overall mortality rate was about 9.4, and it was mainly related to chronic respiratory failure. And the adults with the CGD had significant progressive morbidity, mainly, as I've said before, due to inflammatory complication. Then we come to the management. We've seen that the management of the CGD and the has really improved in the last few years, and this made a rapid, marvelous increase in the overall survival, reaching around 90%. This change has been due to better recognition and awareness for the disease, better laboratory methods for the diagnosis, and better management. And the management of the disease is divided into three main parts: the prophylactic treatment, which is given to every patient, and then treatment if this patient develops an infection, so we treat the acute infection, and finally the long-term and the curative management at the end that we use. So if we talk about, there would be for any patient with an immune deficiency, there should be a general healthcare tips given to them, that they should wash properly their wounds, they should put antiseptic solution. If they're going to do any surgical intervention, whether in their teeth or any surgery, they should have a prophylactic antibiotic, taking care of infections from the lung. If we have a liability for the prerectal abscess and the CGD, should avoid rectal manipulations as suppository or taking rectal temperature. And vaccination should be advised based on the type of the deficiency. For the antimicrobial prophylaxis for patients with chronic granulomatous disease, they should be kept on a prophylactic trimethoprim sulfamethoxazole at a dose of 5 milligrams per kilo per day. And also they should be kept on a prophylactic antifungal. It's better to be the itraconazole is the drug of choice for these patients, as it's very effective against the Aspergillus species. But there are some patients who cannot tolerate the sulfamethoxazoles, or they do have a J6PD deficiency. So they could take a doxycycline or a ciprofloxacin as a prophylactic antibiotic. And for those who could not tolerate the itraconazole, they could use a posaconazole as prophylactic antifungal. And you could also use the gamma interferon as a prophylactic treatment. And we're going to see that there are some variation, as Dr. Goldbatter said, that in North America, they have been using it as a prophylactic management, but in the UK, they have not. It's when we decide to take a recombinant gamma interferon, it's taken as a daily subcutaneous dose. Its main aim is to reduce the frequency and severity of infection and duration of hospitalization. And you could also give it to patients who have acute infections, and this will help us to decrease the hospitalization duration and decrease the severity of infection. The recombinant gamma interferon has been found to be a very safe drug. It has only mild side effects like fever, fatigue, and myalgia. In cases of prophylactic dosage, it should be given 3 times a week at a 5 mic per meter square. For the treatment doses, it should be given daily subcutaneous. For treating serious infection, you should start with an empirical broad-spectrum antibiotics and broad-spectrum antifungal, and then you change based on your culture. You should always have high suspicion that this patient might have fungal infection. And that's why we should add during the treatment empirically the antimicrobial and broad-spectrum antifungals. And the voriconazole is the first line of therapy. Coming to the inflammatory complications, the inflammatory complication management is really challenging because you're going to give an immunosuppressive medication for a patient who has an immune deficiency. So you may trigger more infection, or and patients could enter into more severe complications. That's why it's a bit challenging, and it needs tailoring and good supervision for the patient and good follow-up. For these complications, you could start with a short course of corticosteroids and then do gradual tapping. These are indicated when you have an extensive granuloma, like an obstructive granuloma in the gut or a granuloma in the lung. And you could also give a short course of steroids if you have a liver abscess that is not really responding well to the antimicrobial treatment. You could give the patient also a short course of steroids. Then, if the patient becomes steroid dependent and these inflammatory complications are not controlled by the short course and you need to keep him on a long-term therapy, then you should consider other immunosuppressive medication and biological therapy. And these type of patients, they should be advised to go for bone marrow transplantation. Other lines of treatment used as a second line for the steroids are azathioprine, thalidomide, which blocks the NF-kappa beta, leading to an inhibition of the production of inflammatory cytokines. Infliximab should be used with cautious because of the infections. Anakinra has been used in some studies on a limited number of patients, and it has been giving good results. And finally, those patients, as I said before, should go for bone marrow transplantation. So our curative treatment is the hematopoietic stem cell transplant. But when you send a patient for a transplant, you should keep in your mind the timing, the donor selection, and the conditioning regimen that you are going to use. The transplantation over years now, outcome has been marvelously improving, and the outcome has reached up to 90%. And the studies done on the donors, comparing between the matched unrelated donor 10 out of 10 to the matched sibling donor, and were very comparable, making that if we don't have a matched sibling donor, going for a matched unrelated donor is a good option. And recently, for those X-linked type who do not have a matched donor, they could go for the gene therapy. And this is a very nice table published by the ESID EBMT, showing the guidelines for the transplantation for patients with an X-linked or autosomal recessive chronic granulomatous disease. So they listed down the indication for going to transplant, that you don't have an available special medical care, patients are not compliant to the long-term prophylactic antimicrobial or antifungal, you have one or more life-threatening infection, you have severe granulomatous disease with progressive organ dysfunction, patients are steroid dependent to treat their granulomatous disease, they have an ongoing therapy refractory infection like an aspergillosis, and after emergence of a pre-malignant clone or development of myelodysplastic syndrome. So there have been 2 suggested protocols. Whether you use for the conditioning, you could use the myeloablative conditioning if you're going to use an umbilical cord donor or a haploidentical donor, or you could use reduced intensity conditioning for the matched sibling donor, matched unrelated donor, and the mismatched unrelated donor. And they have collectively done like the average success rate for the different types of donor, and they were almost comparable. As we can see that the matched sibling was a 95.2, whereas the matched unrelated was 90.6. For the mismatch, it was 87. And for the haplo, it was 100%. And the success for the haplo is really now for the new techniques that had been used, like the post-transplant cyclophosphamide, or using alpha-beta depleted T cells, or donor selection for the T cells, and 80% for the umbilical cord. The complication rate is different within each type of a transplant, being 50% for the matched sibling donor, 57.9 in the match unrelated donor, and the 78 for the mismatch, and 33 for the haplo, and 20 for the umbilical. This study was done in the UK. They compared patients, children who had done a transplant, and those who did not do a transplant and only were kept on the supportive care. And interestingly, the survival rate was equivalent in both groups, almost the same. However, the infections and the episodes of surgery, admissions to the hospital, were much more in those who did not go to a transplant. And this was a larger study done of outcome of the hematopoietic stem cells transplantation in the CGT, where they have collected data for 712 children and adults, and they divided the outcome for patients who are less than 18 and for those who are more than 18. And the overall survivor for the patients who were less than 18 at 3 years was 85.7, while for those who are more than 18 was 76%. All patients, the children who are less than 18, when they become old, they had a higher incidence of developing chronic GVHD. And at the end of the story, the transplantation was a very good option with a very good outcome. The graft failure had a very low incidence, and complications were more or less controllable. Going for the X-linked carrier, we have to highlight that these patients, or the carriers, we cannot label them actually as real patients. They could, as we've said, can develop infection and autoimmunity. So you could either put them, if they have infections, on prophylactic antimicrobial and antifungal, or you could go for an immunosuppressive for the autoimmune manifestation. And there have been a study done for 2 exceptional X-linked carriers, female with a refractory inflammatory bowel, had done an allogenic hematopoietic stem cell transplantation because they were refractory to the ordinary treatment. Then we come finally to the new era, which is the gene therapy for the CGD. Gene therapy is an attractive alternative to bone marrow, and it's very a good option for patients who do not have an HLA matched donor. There have been studies from the 1990s for different protocols and different vectors for the gene therapy, but most of them failed because they gave the patients the gene therapy without conditioning. So at the beginning, patient responded properly and they had an improvement in the neutrophil function, but on the long term, they lost the graft. However, so they developed this lentiviral, and they did this study in the US and the UK for patients with an X-linked CGD. There were 9 patients who were enrolled in this study. They took lentiviral gene therapy for the CGD, and they had 2 outcomes in this study. The primary outcome was to assess the safety and the efficacy and stability of the biochemical and the functional reconstitution in the progeny of the engrafted cells at 1 year after doing the gene therapy. And the secondary objective was evaluation and augmentation of immunity against the bacterial and the fungal infection, and assessing the hematopoietic stem cell transduction and engraftment. Unfortunately, in this study, 2 patients died within 3 months of treatment from comorbid because they had a pre-existing comorbidities. The left 6 patients, 6 of them, they had a stable vector copy after 1 year, and they had a persistence of a 16 to 46% of the oxidative positive neutrophil. There was no molecular evidence of clonal dysregulation or any transgene silencing. Accordingly, no incidence for malignancy. Surviving patients had no new CGD-related infection, and 6 of them were able to discontinue the prophylactic antibiotic. At last, we're going to talk about the vaccination for patients with CGD. CGD patient could receive all routine immunization except for a live bacterial vaccine as the BCG and Salmonella. Live vaccines can be given as the measles and varicella, and early influenza are safe and could be given to these patients. Then we come to the second disease, which is the severe congenital neutropenia. Severe congenital neutropenia are rare disease of rare hematological disease. It's characterized by impaired in the maturation of the neutrophil granulocytes. Patients are liable to life-threatening infection that could start early in the first few months of life. And there is a severe predisposition in these type of patients to myelodysplastic syndrome and acute myeloid leukemia. The most frequent pathogens defect are mutations in the LAN gene that encodes the neutrophil elastase, and this is inherited in an autosomal dominant form. And then we have the mutation in the HAX1 gene, which is known as the Costman disease. It contributes to the activation of the granulocyte colony stimulating factor pathway signaling, and it's inherited as autosomal recessive. And then we have a mutation of the glucose 6-phosphatase, and it is an autosomal recessive form. Our diagnosis is done on clinical manifestations, blood neutrophilic count, bone marrow examination, where we find the maturation assess, genetics, and immunological assay. Interestingly, I found that this thing that there are some individual African heritage, they had a low blood neutrophil count compared to white European and Asian persons. And they have relied this low neutrophil count to a specific polymorphism in the DRAC, which encodes the Duffy antigen. However, this is a benign ethnic neutropenia, and it does not indicate that the patient has an immune deficiency and he doesn't develop infections. Coming to the treatment of the severe congenital neutropenia, the treatment, the hallmark of our treatment is to elevate the neutrophil count. So the best treatment is giving patient granulocyte colony stimulating factor. And our target is to elevate the neutrophil count before 1 × 10⁻⁹ per liter. And we should start with a dose of 5 mic per kilo per day and gradually increase every 10 to 15 days. We consider a patient that is not responding to the granulocyte colony stimulating factor if your doses reached 50 mic per kilo, and in some papers they say it's 25 mic per kilo per day, and the neutrophil count is kept still below 0.5. Then these patients should go for the transplant. And from here, different from the CGD, where transplant is considered to be like a first line of treatment, here patient with severe congenital neutropenia, no transplant is used for patients with refractory response to the granulocyte colony stimulating factor, or not only responding, despite that they are on it and still experience life-threatening infection. Also, another indication for the transplant for those who developed acute myeloid leukemia or myelodysplastic syndrome. For vaccination for patients with severe congenital neutropenia, inactivated vaccination could be given as well as seasonal influenza. Live viral vaccines are not contraindicated. Oral polio vaccine, as in all immune deficiency patients, is completely contraindicated. Full routine vaccination for relatives and close contacts is highly recommended, including the seasonal influenza and vaccination against the varicella zoster. And also for these for this entity of people, the relatives and the close contacts, you should not give them oral polio vaccine. Coming for cyclic neutropenia, it's inherited in an autosomal dominant form. There is a mutation in the gene for the neutrophil elastase. These patients have an oscillatory blood neutrophil count occurring within every 14 to 21 days. During the period of the drop, patients start developing painful mouth ulcers, fever, and bacterial infection. Treatment of the cyclic neutropenia is the granulocyte colony stimulating factor, and the main target for my treatment is to shorten the duration and the severity of the neutropenia, elevate the neutrophil count, accordingly decrease the manifestations in the form of fever, ulcers, and infection. The starting dose should be from 1 to 2 milligrams per kilo per day, and most patients will be managed on a less than 30 milligrams per kilo per day. For patients with cyclic neutropenia and asymptomatic, please do not start treatment. You start treatment only when they develop symptoms. Finally, I'm going to talk about the leukocyte adhesion defect. It's an autosomal recessive disease affecting the adhesion migration of the neutrophils. Most common type is the LAD type 1, where neutrophils have profound adhesive and motility defects. For LAD type 2, the neutrophils are unable to bind the selectin receptors on the endothelium, and these patients have neurological manifestation associated with their disease. For LAD type 3, it has been described in few group of patients, and these patients have a defect in the beta integrin in the blood cells, and they have associated liability for bleeding tendency. This is a very nice table published comparing the 3 types of them. All of them, they had a defect delayed in the detachment of the umbilical cord. They had leukocytosis, infection. Periodontitis is common with the LAD type 1. Neurological manifestations is characteristic for type 2, along with the skeletal abnormalities. For type 3, they have a platelet dysfunction, a platelet aggregation as in Gladman, which is very characteristic to them. And recently, in 2015, there have been mentioning for a new type for the LAD, which is type 4, where they have been found in patients with monogenic defect in the cystic fibrosis transmembrane regulatory gene. And these patients have lung infection, and they develop bronchiectasis, bilateral absence of the vas deferens. They have chronic rhinosinusitis, chronic pancreatitis. And for its diagnosis, you diagnose this with a gene mapping for the cystic fibrosis gene. Coming for the treatment for the LAD, for LAD1 and LAD3, transplantation is the hallmark of the treatment. There could be use of some anti-inflammatory medications as the ustekinumab, which is a monoclonal antibody against the P40 subunits common to the interleukin 12 and interleukin 23, has been used successfully to treat refractory periodontitis and sacral ulcers in some case reports. Recombinant gamma interferon also has been used with type 1 in some case reports. A trial of glucose supplements for those in type 2 LAD. Recombinant factor 7A is considered an effective treatment to prevent and to treat the bleeding in a child with LAD type 3. The use of prophylactic immunoglobulin has been done in 2 patients with severe form of LAD to minimize the severity of the infection. Finally, here comes my take-home message. That life expectancy for patients with TGD has been marvelously improved due to the progress in diagnosis and management. Still, the morbidity comes from infections and inflammation in the CGD. Severe congenital neutropenia and cyclic neutropenia should be better treated with granulocytes, colony stimulating factor, except in certain conditions that we have mentioned, as patients who have not responding well to the treatment, or having still infections on top with the treatment. And finally, patients with a leukocyte adhesion defect should go for a transplant. Those for our type 1 and type 3. I would like to thank the ASID, and I would like to thank my team in Ain Shams University, the PAIR team, headed by our former professor, Dr. Yahya Al-Gamal. And I would like to thank all the organizers for the ASID School. Thank you so much.
Okay, thank you so much. So let's start with discussing the results of the case presentation, the vote from the participant. And I think that Professor Nermeen Galal could comment on the results of the vote. Please, Nermeen.
Thank you all for participating in the voting process. The highest number of right results was for the LAD case. Actually, everyone seems to be familiar with the LAD case, followed by the CGD and then the syndromic neutropenia case, and followed by the first case in severe congenital neutropenia. The alternatives to the answers were discussed during the presentation. So I guess if we have anyone who has a question, you may post them in the live chat if you wish. Thank you. On to you, Dr. Rida.
Yes, thank you so much, Nermeen. And so last but not least, the presentation by Dr. Nasreen Radwan. I don't see a question in the chat, but I have few comments and questions maybe to Dr. Nasreen. So thank you again for this excellent presentation. Your talk was really touched many aspects of these different phagocytic defects, either functional or in number of cells. So it was very interesting. And my question is, what about the difficulties we have in our region? Now we are discussing in our settings what is going on in terms of bone marrow transplantation, in terms of course, availability of all these new drugs and for the different pathogen or microorganisms. So what are what is the situation at Cairo, Ain Shams, with regard to bone marrow transplantation? Are you able to transplant all people who need it or not? And if not, what are the results? I've seen a comparative study by the British group between those who do not receive bone marrow and those who do receive it, and it seemed that there were no differences, no major differences in terms of outcome. So what is your opinion with regard to our particular environment with regard to this?
Okay. For our environment, going to a transplant is really needed because patients are not compliant to the prophylactic antimicrobial and antifungal. Besides, not always they can, not only the compliance, but also the availability of the drug because of the financial burdens and things like that. So they get more and more infections and they complicate, and it ends up that they are not suitable for going to the transplant. Unfortunately, for the chronic granulomatous disease, we haven't transplanted a lot, but there are few patients who went and rushed into the transplant, and their outcome, thanks God, was really good. One of them had a disseminated BCGiosis and all improved after the transplant. He was transplanted a few years ago, and it's now grown and is really very good. But those who get reluctant in finishing the paperwork and waiting, taking the decision to go into transplant, they really get complicated and they miss the chance for a transplant. We have in Ain Shams University had the chance to use the gamma interferon in around 3 patients of us, but unfortunately we didn't find a difference for these patients. We don't know, we used it during the severe infections, but the outcome was not really helpful. We don't know, maybe if we stayed longer, it could have given us a better outcome. I'm not sure, but we stopped using it. It's expensive. We find a lot of difficulties to getting it abroad. So we stopped using it actually in these patients.
Yes, actually we had similar experience. We started some time ago to do it, but now it's really very difficult to get the approval from the social security system here. So it's a real problem. That's why I'm wondering about the strategies that we should develop in our settings. It's very difficult to go very rapidly to all these new drugs and this gene therapy and so on. So it's very difficult. For example, with the monoclonal antibodies, the inflammatory monoclonal antibodies, do you have some experience with that in CGD, for example, with granulomatosis?
No, we have not. In our center, we don't. We have not used.
Yeah, same for us. Okay. Earlier, I've seen in the chat, much earlier, one question about gene therapy in LAD, and one of the students was asking, I think. And what I know is that gene therapy in LAD is at the first clinical steps. There is a company, Rocket Pharmaceutical, who got in touch with us to have some patients They are in phase 1 clinical trials. So it's, I think it's, that's what I have as information to give to the person, the colleague who did ask this question. Okay, so thank you again, Nasreen. Are there other questions to Nasreen from you, Nahla, or from any of the colleagues present?
No, it was actually a very informative. Yeah, it was a very informative talk, Nasreen. So thank you very much for that. I noticed the question in the chat. I think it was meant to go to Professor Goldblatt. So somebody apparently posted a question about considering skewing or lionization in XL CGD carriers as they get older. She was asking whether he would recommend a cutoff in DHR to consider prophylaxis. And then there was another question about the use of antimicrobial prophylaxis for infections in addition to monitoring for autoimmune diseases. I'm not 100% sure about what's really meant by the question, but what I did was I directed the student directly to Professor Goldblatt. I don't know whether any of the faculty have any answers or comments on these questions.
Nahla, I want to ask her, he's asking about giving prophylaxis to the X-linked carriers, or
I'm not sure what's the question here. It just says antimicrobial prophylaxis for infections in addition to monitoring for autoimmune disease. So I'm not 100% sure what that means. I mean, what's the question? There isn't, so that's why I thought I would direct her directly to the professor through email. Yeah.
I think this was covered in Nasreen's talk, so maybe this was posted before her talk after Professor Goldblatt left, right?
Yeah. Okay. So if there are any, if there aren't any more questions, are there any other questions? No? Okay. So shall we wrap up? Professor
Yes,
Rida?
sure, Nahla. Up to you.
Please? Yeah. I will hand the floor on to you. You are our
okay. So I thought you would like to do.
moderator
so it
and
was
chair.
Really a nice question, I think. Yeah, thank you so much, Nahla. So it was, I think, the nice school. We had very broad presentation on all aspects of phagocytic function defects, and I think that the program that has been prepared once again by Reem was really excellent. I would like to mention that all the talks have been followed by interesting discussion, and that's the objective. I hope that all students will participate to this quiz questions and validate their contribution. The ASID board for this new opportunity to have this interaction with the students and young investigators in Africa around very hot topics and important primary immunodeficiency or inborn errors of immunity diseases that we are dealing with in the continent. So thank you again. Thank you to all the speakers. I have nothing to add, and I wish to have the opportunity to be with you at the next ASID School. Who knows, the 17th, maybe in-person format. It is time to come back to our meetings, hopefully soon. And I think that we should plan for our Congress, of course, and furthermore and more schools in the near future. So thank you again to everyone, and I declare this session closed. And thank you so much for your contributions. Bye-bye.
Thank you. Bye. Bye. Thank you very much.